3, selamat pagi. Coba dari luar.
Cek 1 2 3.
Cek, aman-aman dok, aman. Cek,
Minta si Yes. Ini baru yang baru.
Cek.
Maafkan saya. Sini, kita lihat slide ya. Sudah. Udah kelihatan pakai slide-nya, Dek. Pun, Dek. Belum. Mana slide show-nya, Dek? Oh, di. Ya. Yang kelak slide. Oh iya. Slide yang lain, Dek. Yap. Udah cukup. Yap.
Nah, dah.
How about getting your shipping rates calculated in 30 seconds?
May we have your attention, please, because the event is about to start. Good morning, professors, doctors, teachers, colleagues, and all the participants. On behalf of the committee, I would like to extend a warm welcome for everyone for taking the time to attend this event. It is an honor to welcome to our honorary guest, Francis J. Podbilski, MD, FICS, as Executive Director of ICS.
Professor Dr. Sri Maliawan, neurosurgeon, FICS as a president of ICS Indonesia section.
Dr. Gede Eka Wiratnaya, orthopedic surgeon, as representative of Dean of Faculty of Medicine, Udayana University.
Dr. I Ketut Widiasa, MPH, MH FISQA, Head of Indonesia Doctor Association, Denpasar.
All moderators and speakers, and all fellow doctors, teachers, colleagues, and we also welcome those who have joined us online. Om Swastiastu. Assalamualaikum warahmatullahi wabarakatuh.
Shalom,
Salam sejahtera,
Namo Buddhaya.
salam kebajikan. My name is Ardi.
And I am Jaslyn. It is an honor for us to be the host in this event. And we welcome you to today's seminar, which carries the theme
From research to medical practice, new era in Indonesia.
Now we would like to invite everyone to stand up to sing our national anthem of Indonesia Raya.
For all the audiences, please remain standing. Next, we shall start the event with prayers. The prayer will be guided according to Hindu prayer. To other religion, please pray accordingly.
Ladies and gentlemen, let us bow our heads and calm our hearts in humility as we seek His blessings and guidance. We offer this prayer according to the Hindu faith. Others may adapt it to their own beliefs. Om Wignamastu Namasidam. Om Siddharastu Tarastu Swaha. Om Aditya Param Jyotir Rakta Tejo Namastute Sweta Pangkaja Madhyasta Bhaskaraya Nama Nama Om Rang Ring Sya Paramashiwa Ditya Nama Swaha. Om Wignamastu, Tuhan yang Maha Bijaksana. Kami bersyukur atas kesempatan yang Engkau berikan, sehingga kami dapat berkumpul di tempat ini dalam keadaan sehat. Kami memohon agar Engkau memberkati simposium ini, agar dapat berjalan dengan lancar dan penuh manfaat. Bimbinglah kami dalam setiap langkah, agar apa yang kami diskusikan dan pelajari hari ini dapat memberi wawasan baru, membawa kebaikan, serta memberikan manfaat yang nyata bagi sesama dan lingkungan. Om Dewa Suksema Parama Sintia Ya Nama Swaha. Sarwa Karya Presidantam. Om Shanti 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 Om.
Thank you, everyone. Please take your seats.
Now, to give an opening remark, we would like to call upon the President of ICS Indonesia Section and also Professor of Neurological Division of the Faculty of Medicine, Udayana University. Please welcome Professor Dr. Sri Maliawan, Neurosurgeon FICS. Professor Sri Maliawan, the time is yours.
Om Swastiastu. Assalamualaikum, salam, namo buddhaya, salam sehat untuk kita semua. Ladies and gentlemen, esteemed colleagues and honored guests, good morning and welcome to the one-day hybrid FICS seminar. It is a great pleasure to see you and see so many dedicated professionals gather here today, united by our shared community to advancing the field of surgery and improving patient care worldwide. I was very happy to see the participants who were recorded as it's already registered 400 people online and offline here. And then we have recorded also there is 16 free paper. It will be contested in this seminar. Almost from all over Indonesia, there are 15 speakers. And because that we have overseas speaker also, offline and online in this seminar. And as we embark on this journey to one day today, we have the unique opportunity to engage with some of the brightest mind in our field. We will explore innovative technique, share groundbreaking research, and discuss the challenges we face in our practice. This seminar is also just a platform for learning. It is a space for collaboration, inspiration, and the exchange of ideas that can shape the future of surgical practice. I would like to take a moment to acknowledge the hard work and dedication of the organizing committee, whose effort have made this event possible. Their commitment to excellence ensures that we have a rich program filled with insightful presentation, interactive, accompanied with a Q&A nanti later, and valuable networking opportunities. Throughout this seminar, I encourage each of you to actively participate, ask questions, and share your experiences. The diversity of perspective in this room is our greatest asset. And it is through our collective knowledge that we can drive progress in our field. As we delve into the session, let us remember the core values that bind us as a surgeon are compassion, integrity, and a relentless pursuit of knowledge. Together, we can push the boundaries of what is possible in surgery and ultimately enhance the life of our patient. Thank you for being here, and I look forward to an engaging and fruitful seminar. Let us make the most of this opportunity to learn from one another and to inspire each other. Again, thank you for your participation in this seminar. And also, this is a free seminar. The aim and the goal of this seminar is to share knowledge. We are non-profit activities. We start from ICS Indonesia section. So again, because when I was just graduated and medical student, I was sent to the remote area, very remote in East Timor and in Nusa Penida. At that time, there's very difficult access to that island. So based on that experience, I cannot afford and attend any just maybe national speaker, let alone international standard for the seminar like this. Okay, that's why I myself want and desire to devote this organization to let our colleagues and our friend in the remote area to can attend and got certificate recognized by Minister of Health. Also to attend maybe world-class presentation. And we have a special guest here, Professor Francis. Thank you for your coming here and your share your knowledge and experience. So again, thank you. Please enjoy and participate in this seminar. And don't forget, this was shared worldwide and already officially registered 400 participants already registered in this seminar. Thank you. Om Santi, Santi, Santi. Thank you.
Thank you, Professor Sri Maliawan.
Next, we would like to invite Dr. Igede Eka Wiratnaya, orthopedic surgeon, as the representative of the Dean of the Faculty of Medicine, Udayana University. To Dr. Eka Wiratnaya, the time is yours.
Good morning, everybody. And I would like to say warm greeting to all of you with the Indonesia greeting. Om Swastiastu, Assalamualaikum warahmatullahi wabarakatuh, salam, salam sejahtera, namo buddhaya, salam rahayu untuk kita semua. First, dear Honorable Director Executive from IGS, Professor Francis, welcome to Bali. And a special welcome to our Faculty of Medicine Udayana University. And of course, the president of IGS Indonesian section, that's Professor Sri Maliawan, is my teacher. And then of course, Dr. Manopo here as a represent to IGS too. And then all our colleagues here, then really, what's called, happy to see you all here. And then I would like, of course, thanks to God, because in the morning we stay here together, still have a time to discuss, and then we'll have a lot of experience, especially of the knowledge. Then, as well as Professor Francis here he's coming from Chicago. It's very long flight, I know that. Thank you so much to come here. And then one that I would like to say to all of you, and especially for Francis, because it's first time come to Bali, that in Faculty of Medicine Udayana University, now we have a 37 study program. Then the study program, and mostly the specialty of study programs, program study of specialists. That's we have another study program, of course, but mostly our study program is specialist program. And then one of our concern about that is how to, this topic is very nice because we have a lot of research, but we really, very small number of our research will apply to be a clinical practice. That's why we need that for in the future to improve that, because our goal in the future, how to implementing all the research, especially for the clinical research, can be translated to the clinical practice. That's why we hopefully in the topic today will be support us and encourage us to imply all the clinical research to be a clinical practice. That's very, very beautiful topic today. And then of course, we thank to all of you here. And one of from this association of the Indonesia doctor, please coming in the broadcast, please down here, Dr. Widyasa. Yeah, I'm so sorry because I just see you there. And then, of course, we are really, really appreciate to all of you here to stay, to share your time, then join together. Even though in online meeting, some of you stay in the online, but we know that really, really difficult to get a time. But as a surgeon especially, we know that it's very difficult to get a time. Even though in the holiday time today, you know that, you stay here to share your time. I know you're very tired, and because you encourage yourself to improve yourself, you come here and want to discuss, want to, to extend your knowledge, and then you want to stay here. That's really, really grateful for me. Then I don't want to take you a lot of time because you will have a lot of discussion as well. You to be speaker for Francis. We want to hear. They want to hear all your what's called new perspective about the clinical practice based on the clinical research. And once again, I would like to express our high appreciation to all of you to stay here. That of course, in the future, our collaboration will be strengthened again. And of course, I invite you come to Bali again, especially you, one of the very what's called difficult surgeon to get in Indonesia. We just have the new program for the thoracic surgeon in Indonesia. That's why in the future, hopefully, we have collaboration with you and our study program, especially thoracic surgeon in Bali. We have the thoracic surgeon specialty in Bali too. Yeah, because the committee would like to ask me to open this meeting, right? I would like to say the thanks to God to today. I just say the meeting, the symposium of the IHS officially open. Once again, thank you so much. I just finished my remark with the Om Santi 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 Om. Assalamualaikum, salam, salam sejahtera, namo buddhaya, salam rahayu untuk kita semua. Terima kasih.
Thank you, Dr. Igede Eka Wiratnaya, orthopedic surgeon.
Now, since the event officially started, we would like to invite Francis de Podbilski, MD, FICS, as the Executive Director of ICS to give a welcome speech for this event. For Dr. Francis, the time is yours.
Good morning. I bring you greetings from the International College of Surgeons World Body, from Professor Guido Parquet, the president, and Mr. Max Downham, the executive director. I'm from the US section, so I bring you greetings from the United States section as well. I'm very happy to say that the International College of Surgeons US section and the Indonesia section has had such a warm and close relationship over the years. For those of you who don't know, the International College of Surgeons was founded in 1938 by Dr. Max Thorek. And Dr. Thorek saw the need for two things in the world in terms of surgery: education and service. And these are two things that are going to be addressed in the conference today: education on the latest surgical techniques to provide outstanding care for our patients, and service to people in the world who need those services that may not necessarily be able to afford them or be available to receive them. So on behalf of the International College of Surgeons, I congratulate you. I congratulate Professor Maliwalan as president of the Indonesia section, and Professor Manopo as well, who answered the call during COVID when I was fortunate enough to come in 2015 in Surabaya to speak to all of you. But when COVID hit, everything in the world came to a stop. And Professor Manopo in the Indonesia section took the lead to make sure that education didn't stop during this terrible pandemic. And they started their Zoom conferences to make sure that we were able, and they were able, to afford education to not only the Indonesia section, but the rest of the world. And I'm amused to say that the United States followed the lead of the Indonesia section after a couple of years of the great successes that they've had in their online Zoom webinars. And now the United States section is following the leader, and the leader being the Indonesia section. So on that official note, I thank the committee for the invitation to attend today. I congratulate the Indonesia section, and I look forward to learning some things today from the speakers who are here. So with that, I'll conclude and say thank you.
Thank you for your speech, Dr. Francis.
At this time, let us welcome Dr. Iketut Widiasa, MPH, MH FISQA, who will be presenting on the topic Ethics in the Medical Profession. Please welcome Dr. Iketut Widiasa.
Thank you for the time, and thank you also for the opportunities to our professional organization and Nation Medical Association Denpasar branch to standing be standing in front of our honorable lecturers, esteemed guests, and also my fellow healthcare professionals. Today, I'm Dr. Widyasa. I'm the chief of Indonesian Medical Association Denpasar branch. Please give me a chance to welcoming from Professor Francis, the president of FICS, and also Prof. Manopo, and also my honorable lecturer, Prof. Sri Malyawan, the dean, my colleagues, Dr. Eka, and also all of the audience and the participant of this ICS symposium. Next. Today, I will have a part of our ethical conduct, ethical code of Indonesian medical code of conduct. So the main things in our relationship to among doctor and patients is the communication. But before I present my presentation, please slide. Please let us concern to today's or that our colleagues, our college, Dr. Silea Olympia Melita, has a trial to prove that she didn't make any mistake in their practice. So she faced the trial to in our court, that she faced that she assumed that patient has minor complication from her treatment earlier. So please let me say that Dr. Celia has can go through this trial process. Okay, next slide. Sorry, this is the news from Sabang in Aceh. That's the patient has died from our treatment, that the nurse give the alprazolam, that when the patient has no slide. So the patient has died that because of the alprazolam that the nurse give, but the patient or the family of the patient that say that the nurse didn't give enough information about the medicine. So this patient through the CT scan processes, because the children is not too good in the condition that the patient given from alprazolam, that through after the CT scan, patient has died. So next. So the main problem that patient or their relative said that the nurse didn't give enough information about the medicine through the CT scan procedure. Next. So I would like to say that this is the nature of our patient. People who trust the doctor to solve their health problems. Patient also entrust their need to the doctors, and the patient are the people who place their hopes on doctors to help them, and then people who long for honest, polite, and wise attitude and behavior from the doctor when treating the patients. Patient is also the people who are included in vulnerable groups, so their dignity and rights needs to be protected, including their human rights. Slide. And our medical profession, that we have to believe that it is a noble profession. And medical profession also requires certain competencies and adequate minimum level of competence. Our medical profession is also primary orientation is more directed toward to interest of the society. So we are an altruistic profession. We also must pay attention to patient values and rights, including the patient human rights. Medical profession is also has rules to regulate oneself, and we call it self-disciplining, and we perform it in the form of a code of ethics. To become a doctor must have a good competence and also good character. The good competence includes hard competence, including knowledge and skills that our symposiums today, we improving our competence, and from next session, we will be improve our skill. Also that clinical, including the clinical skill, clinical judgment, and also we have to be a good doctor, we have a good communication skills. From the soft competence, we have to have moral, ethical, and humanistic. Slide. So when we want to be a doctor, competent doctor, a good doctor, we have to fulfill that good competence and also a good character. Slide. Baik, according to our national or international consensus of medical profession, so when we practice our professional medicine, we have to follow at least four things to follow. First, the professional standards. 1, 2 is ethical. 3 is disciplines, and also the health law. So we have to follow. There are four standards, including professional standard, ethical standard, disciplines, and also the health law regulation. In the concept of doctor-patient communication in Indonesian doctor competency standard, we believe that sebelumnya, yeah, we have to remind ourselves that to become a competent doctor. Slide. Yeah, we have to have these 7 things to have. Then we can knowledge by that a competent doctor. We have 3 basis things. Hyper personality, self-awareness, and self-development, and also the effective communication. And the 4th, for the information management, scientific basis of medicine, clinical skills, and also health problems management. So we have to fulfill these 7 things, 7 competence to become a good or competent doctor. When we discuss about effective communication, slide. Our standard, our competency standard is true to these 3 things. When we have good communication with patient and their families, communicating with partners, doctors, nurses, and also the other health professional. And also we have 2 competence when we communicating with the community. Next. So when one of our competency that what we have to fulfill, that we have to make good communication with the patient and family. When communicating with patient and their families, like we have to build relationships through the verbal and non-verbal communication, and also we have to show our empathy verbally and non-verbally, communicating using polite and understandable language. Listening, next slide. Listening actively to explore health issues holistically and comprehensively. and then conveying health-related information. So including that, we have to make a good strategies to delivering a bad news and also the informed consent and conducting counseling in a polite, good, and correct manner. We also have to demonstrating our sensitivity to the bio, physical, social, cultural, and spiritual aspect of patient and families during during doctor-patient communication. Slide. Next. And the other concept of doctor-patient communication in Indonesian Code of Medical Ethics that we believe we have 22 article of in Indonesian Code of Medical Ethics. One of them in Article 10 of our Kodeki, we call it next. We call it Kodeki, the Code of Indonesian Medical Ethics, Kode Etik Kedokteran Indonesia. In Article number 10, that we have to respect the right of patient and their colleagues and our colleagues. In through the article, in Article 10, we have to always respect the rights of patients, colleagues, and other health workers, and must maintain patient trust. Next slide. And the scope of our Article 10 of Kodeki, there's of 6 scope of this article, but through the to follow the communication, doctor-patient communication, there's a 4 and number 4 and number 5 of this article of the scope of this article, that this is our obligation in implementing effective communication with our patient. In number 4, we as a doctor is obliged to provide clear and adequate information and respect the patient opinion or response to the doctor's explanation. So when we delivering our information, so we have to prepare whatever their response, and we have to make a good answer for their question. A doctor should not hide information that a patient needs unless the doctor believes it is a patient best interest, in which case the doctor can convey this information to the patient family or their guardians. Next slide. So patients have the right to obtain information from their doctors and discuss the benefits, risks, and appropriate treatment for themselves, and must receive professional guidance and direction from their doctors in making decisions. Patients or their families have the right to submit complaints, criticism, and suggestion regarding medical services, and doctor should pay attention and respond wholeheartedly. Next slide. And according to our Indonesian medical discipline or regulation, we do have a regulation about the discipline for the doctors and dentists. And according to the rules or regulation, the violation. Next slide. Yeah. In our regulation, discipline regulation, medical regulation, the violation of professional discipline can be grouped in 3 groups. First, carrying out medical practice incompetently, professional that duties and responsibility to patient are not carried out properly, and behaving in a despicable manner that damages the dignity and honor of the medical profession. Slide. And from this discipline regulation, we do have 28 forms of medical discipline violation. And violation of medical discipline in the implementation of doctor-patient communication. Slide. Next. That there's 2 articles in our discipline, professional discipline regulation in Article 8 and Article 9. In Article 8, the violation of medical discipline in the implementation of doctor-patient, that not providing honest, ethical, and adequate information to the patient or their families in carrying out medical practice. And in Article 9, that the violation is carrying out the medical procedure or care without obtaining consent from the patient or a close family, guardian, and custodian. So this is the quote of in the end of my presentation. The aspect of effective doctor-patient communication is one of the basic competency to become a good doctor, and has also become one of doctor obligation as regulated in the Indonesian Code of Medical Ethics. And when the doctor has carried out this obligation as well as possible, then be assured that the doctor will be able to avoid the risk of medical discipline violation. And as George Bernard Shaw said, that the single biggest problem in our communication is the illusion that the communication has occurred. So that's my last slide. So thank you for the chance, and this is my first presentation in front of the ICS. So sorry if the presentation is not too good. Thank you very much and good morning.
Thank you for the outstanding presentation, Dr. Iketut Widiasa.
Ladies and gentlemen, the next part of our agenda is the lecture from our respected expert who will be sharing their knowledge and insight. This session will feature a presentation and also discussion afterward. This session will be divided into two sessions, which will be online and offline session. The online session will be started later at 10 a.m., which will be moderated by Dr. Gede Warasamsarga, plastic surgeon. And as for the offline session, we will start now with the moderator of the first session is Dr. Heru Sutanto Kurniawan, General Surgeon. For moderator, please go to the stage. Okay, before we start the session, we will take group picture first. Kasih backgroundnya. On the count of three. 1, 2, 3. 1, 2, 3. Okay, now we will start our first session. Please welcome our moderator, Dr. Heru Sutanto Kurniawan, General Surgeon.
On the first session, we will talk about medical ethics and the advance of the medical technology in the world, especially in the US actually. And we will also discuss about the oncological advance in the world currently. So there will be five speakers. So the first speakers will be Dr. Peter J. Manongpo actually. He will talk about the ethics concern in surgical AI. Dr. Peter is an assistant professor in Ciputa University. He is concerned in medical and bioethic actually. So the time is yours.
Thank you, Mr. Moderator. Dear participants, good morning and Om Swastiastu. Assalamualaikum. Salam kebajikan, nama budaya. Rahayu Rahayu, Astungkara. Slide, please. Today, I would like to share with all of you the ethical concerns in surgical artificial intelligence. Why I choose these topics, because nowadays it is growing, emerging issues in surgery. Next, please. This is the disclaimer. Maybe one slide before, yeah. I have no financial concern, and also there are no competing interests in this presentation. Next, please. This is a disclaimer. Next, please. Yeah, I would like to share this picture with you because it represents the multidisciplinary science in ethics. Yeah. Here, when I was joining my study in Leuven University in Belgium, 2017, I have many colleagues from other disciplines. I was the only medical discipline. This one is psychologist from Italy. This one is lawyer from UK. And she is the sociologist from the United States. It's me, and this is my professor in ethics from the Leuven University. And this is the anthropologist from France. So you can see here that talking about ethics, that's not only about medical ethics, but wider. Next slide, please. This is the reading material. I think you can enhance a better perspective to understand on medical ethics, particularly in surgical AI. The first is Principlism by Bochum et al. And the Surgical Artificial Intelligence by FICS. Ethical Dilemmas in Surgical AI by Capianci, and also the AE and Clinical Decision Making in Emergency Surgery. Next, please. This is what we're talking about, artificial intelligence in surgery, prima facie duty. Prima facie is the first site that how the doctors should behave on ethics. Respect for autonomy and person, confidentiality, privacy, data governance and security, transparency, safety, technical robustness and errors. Technical robustness is the strong, the power of techniques. Fairness and ethical decision making. Next, please. The background of the talk of today in my presentation is surgical AI is a growing issue. It emerged from the AI in surgery, and needed for improving surgical outcomes, enhancing surgeon performance, optimizing patient safety. But surgical AI might raise ethical dilemmas, such violation against respect for autonomy, the patient autonomy, and all the other health stakeholders' autonomy, and also the confidentiality, privacy about the data, transparency, data protection, and safety. Of course, this is about patient safety. This is very important. Patient safety for the maintaining of the quality of patient management. Therefore, prudent handling of surgical AI is paramount, very important, to avoid the unethical misconduct. Next, please. So, our intention were respecting the prima facie principle of autonomy. What is that prima facie? Based on the four principles, autonomy, non-maleficence, beneficence, justice, and the respect for human life, human rights, and human dignity, recognizing the ethical surgical AI, finding out how about the ethical concern that might raise, and also fixing and resolving the origin of ethical dispute. Also, surgeons should be aware of the ethical, legal, and regulatory norms and standards, either national and international, in surgical AI. The core documents of the World Medical Association are paramount to be understood by surgeons. The first is the Declaration of Geneva. This content of the Physicians' Pledge, the Declaration of Helsinki. This is about the research of the human subject research. And also the International Code of Medical Ethics, or ICOME. This including the burnout and then the conscience of the physicians to refuse to do some procedures by some beliefs. Next, please. How to do it? First, based on the awareness of prima facie duty that I've mentioned before, and also the implementation of the surgical AI with the four bioethical principles. These are the respect for autonomy and person, non-maleficence or doing no harm, beneficence or doing good for others, and justice based on fairness and equality. Doing surgical AI with prudent and ethical awareness, and also the dignity enhancing care. How to change vulnerability into dignity. Next, please. So what are the surgical AI or surgical artificial intelligence? My senior Professor Podbilski will explain it later in details. First is image analysis and visualization. Second is robotic surgery, and also intraoperative decision support, patient monitoring, surgical education and training, precision surgery and accuracy, minimally invasive surgery, patient safety, and good data quality and algorithms. Next, please. So this is the algorithm of the artificial intelligence with the ethical dilemmas and the open issues. You can read by yourself in my slides. And also these 6 ethical issues are related to the other open issues on surgical AI. Next, please. So what are the ethical concerns? First, about the respect for autonomy. The patient should be provided with informed consent, proper informed consent. Confidentiality, privacy and security, and also fairness, transparency, and no discrimination on any issues, patient safety, less human touch, and more robust techniques in AI surgery. Data governance, who will guarantee all the surgical or health stakeholders should be responsible for this data governance, and also ethical deliberation and humanities. Next, please. This is my last slide. The concluding remarks. The first is surgical AI is needed, but should be faced with prudent ethical awareness, respecting for the patient's life, human rights, human dignity, and patient safety should be prioritized. This is very important. Good communication with patient is needed, as patients should be explained about surgical AI completely, about the benefits, about the risks, about the other options, and exactly for the cost, because this need a huge cost. Surgical AI should be carried out based on the proper ethical and clinical ground, both. Further research is needed because it is a growing issue and should elaborate these surgical eye circumstances. Next, please. Yeah, this is my acknowledgement. This is Professor Emnon Karmi. I have made some discussion on this issue when I met him in Jerusalem, Israel, because he is the international chair on bioethics president. And also Professor Daniel Sulmasi from the University of Chicago. May Professor Potbisi know him, and for inspiring to prepare this presentation. Next, please. Yeah, thank you very much for your kind attention. Om Santi 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 Asungkar.
Okay, next speaker is Professor Francis J. Podbielski. He is a clinical professor of surgery in University of Illinois, Chicago University, US, and then he is also chief of thoracic surgery. He will talk about current robotic and artificial intelligence in surgery in the United States. So you will have 45 minutes, Prof.
Rather than, because I like to move around, I'm not going to stand behind the podium. I think my presentation on artificial intelligence and robotic surgery was kind of, but will be an excellent follow-up to some of the issues that Professor Minopo talked about in terms of letting robotics and artificial intelligence run the operation for you. I have no financial disclosures to make. So let's start with a brief outline of what I'm going to talk about. We're going to talk what is artificial intelligence exactly, talk about some complex, minimally invasive and robotic surgery. Without artificial intelligence, we really wouldn't be able to do these procedures, and they are incredible. And then go into a little bit of the philosophy of, as we gain more and more knowledge and have machines do more and more of the work for us, is it possible to forget the knowledge that we've learned over the centuries and millennia and become up short? And then talk about a very sad example of the pitfalls of over-reliance of technology, and then briefly conclude with attitudes in the US about minimally invasive surgery and technology in medicine, and then a few perspectives for the future. So if you go to the internet and ask yourself, what is artificial? Well, what is artificial? It's something made or done by humans to seem like it's natural, like an artificial coral reef. What is intelligence? The ability to learn or understand or solve a problem and interact with the environment to get the result you want. But when you combine the two together, it's the capability of computer systems to imitate intelligent human behavior. And I want to stress, imitate intelligent human behavior, not replicate it. And I think the best thing definition was by Liz Freeman. Artificial intelligence applications up to now have worked best in the background in hospitals to do automated scheduling, workforce, how long do operations take, optimize, operative flow and whatnot, but not necessarily do the operations independently or even with surgeon help. So in its very broadest sense, artificial intelligence is just machines that are kind of capable of sensing the environment, receiving stimulus, perception, logic, and basic learning. Then when you take the next step to machine learning, you take that interaction with the environment, turn it into algorithms, predictions, how things are going to come out, and then those machines get better. The more data they get, the smarter the machines get. But then this is the real step to deep learning, where you stop having the machines in complete control of human beings. You have the machines talking to one another to solve what they perceive are problems in terms of perception and how to proceed sometimes independently of human input. This is where artificial intelligence, as Professor Manopal pointed out, starts to run into a bit of problem with what we're doing in society. So if we talk about artificial intelligence, in my opinion, this is the first example of artificial intelligence. You have a machine doing the work for you. It goes back about 3 millennia to the Sumerians in the Middle East. It's an abacus, everybody knows that. But by manipulating this machine, it can give you an answer. So it's basically artificial intelligence. And that was the standard of artificial intelligence for a long time, until in England in 1620, a mathematician and theologian named Leibniz came up with a slide rule. This slide rule, artificial intelligence, you're putting data in and it's giving you data back. This is what got us into outer space. It's what helped us develop nuclear energy research, all of it without a machine that you plug into a wall, but nonetheless artificial, a tool, if you will. And that was the standard. Until the mid-1950s, when International Business and Machines came out with a computer. So this is 1953. This computer that you see is the first thing you plug into a wall, you input data, and it gives you data back. This computer that you see took out part of a room and is probably only 100,000th time as strong as what you have or carrying with you in terms of a cell phone. And this got better over time, over the next decades. It got better until the TI-55 calculator. Now, most of you are too young to remember that. You guys probably remember that. I very proudly bought one of these in 1977 when I was in high school and carried around on my belt loop like a badge of honor, because it could do great things. It could do basic mathematics. It could do logarithmics. It could do square roots. It could do basic trigonometry. But a long way from that big computer that was in that occupied that entire room. And now you have smartphones. These are just generations beyond what we've had in terms of that TI-55 calculator that can not only do calculations, but can tell you elevations, where you're at in the world, find directions for you. And that's not even the end of it. Now, over the last few years, if you're in a remote area and you have your smartphone and you have something you can plug into it, you can do real-time ultrasound on someone on your phone. That's absolutely incredible advance in technology. Again, this probe isn't smart itself. You're putting input into it and then you're interpreting what that data is. So we've come a long way in terms of intelligent, but are these machines really intelligent? One of the sarcastic definitions of artificial intelligence is plausible hallucinations, which means if you can put some data in, the machine can tell you something, but it doesn't necessarily have to make any sense. It's just plausible. But in reality, AI is an excellent way to solve a statistical problem because it can take so much data in at one time. It can process it so fast and spit out answers for you that it is of great value. And it's best characterized by a rapid, predictable way using algorithmic output when confronted with a data set. But the data set is what the problem is that, again, was previously referred. Data acquisition is the key to helping the machine learn the truth. So if you have machines learning from Facebook or Instagram, are they really going to give you the truth, or are they just going to give you whatever someone has fed into them? So this is a big problem that we're starting to confront with medicine. If you don't give accurate information to the machine, how do you expect it to give you an accurate answer? But they do predict human behavior and suggest warnings and complex systems of medicine in the intensive care unit, in the cockpit of a commercial airliner where you just have a whole panel of displays with blinking lights and whatnot. You know, the computer can pick those things up and give you a little hint if there's a problem that you need to address. So it's very helpful. And without these technologies, the next three cases we're going to discuss are very complex cases in surgery that wouldn't be possible with this technology and artificial intelligence. So let's talk about three distinct cases, and they're wonderful cases. The first one, as you can see, is going to be a hiatal hernia repair. These are all in the public domain. You can go on YouTube and look them up, and they're there. I did not do these cases because I'm not quite that good. But you can see with the machine, the visualization, the optics and everything. And for those of you who have done hiatal hernia repair, you're really deep in a hole. It's hard to see anything. A lot of that dissection you do is with your finger blindly. Whereas here you can see everything. The machine is showing you everything. The motion of the instruments is helping you with your dissection here along the right cruce. You can get up into the chest. You can get so far up almost to the inferior pulmonary veins to do your hernia repair. And unless you had a complex computer running in the background, coordinating your movements on the console through the computer, looking at the optics, none of this would happen. So this is machine learning, artificial intelligence, and you'll see sometimes at the bottom of the screen that there'll be a warning. My video has stopped running. That's probably buffering. You'll see a warning that there's a problem. Here you can see they're dissecting around the back of the esophagus. And what they're going to do is they're going to pass a drain around so they can lift up the esophagus to get to their repair. This surgeon has a rather ingenious modification to the drain. They cut a little slit in it. So what they can do is reach through that slit, grab the drain on the other side, like a little sling, lift up, and then pass an instrument from the outside and just hold up. The assistant's holding up and the surgeon is continuing the dissection behind the esophagus on the right side. And again, way up into the chest to complete the dissection around the esophagus on the right side. And then they'll come up along the top, take more of the hernia sac out to make sure that all they have is strictly esophagus to provide the most reliable repair. And when they go to put the patch in. And it's critical that you get this sac out to make sure that your repair is durable. But when you do this open, looking into a deep hole, a lot of this dissection that you see, you've actually just done digitally. So now they're going to work on the left side of the cruce. They're going to get the sac cleared away on that side. Again, they have special cautery devices that you can use with your foot pedal and provide cautery for good hemostasis. And the left cruce comes into view here. They're going to be careful up in the corner to make sure that they don't hit the spleen. And then they just follow that cruce all the way down and around to make sure that they're completely around the esophagus itself. And you could see in the corner, there was a little warning there by the machine that you were too much tension on the tissue or your instruments were out of range of visualization. And here you can see the endoscopic suturing that they use. These researchers and these surgeons use a little bit different kind of knot tying with an extracorporeal knot tie with a clip. And they'll put anywhere from 2 to 3 stitches in the posterior cruce to tighten that space up. And here they're going to put the second stitch in and they've applied that clip. Then they'll put the esophagus down. They'll look at the top and see if they need a stitch here. And remember, you have to make sure you don't make this too tight because then the food won't get down through the gastroesophageal junction. So some people will put a bougie down to make sure that the repair isn't too tight. And here they're putting that stitch in anteriorly and passing the knot tire along here to tie that. Here you can see on the undersurface of the diaphragm, you can see there's a big vein that runs there. You need to be careful when you're doing hiatal hernia repairs that you don't get into that vein because it's very difficult to fix because the heart is on the other side of the pericardium. So you can't just take a big stitch to try to ligate the vein or you can injure the heart. So here they've finished their dissection. They're going to put a piece of bioabsorbable mush in, and they're going to pass it around the back with that little U cut out of it. And then once they get it straightened out, they'll move this out of the way. You can see the spleen back there. We want to avoid him. And they take a stitch and they sew the mesh or they tack the mesh to the underside of the diaphragm. And then use this knot tire to come in to secure the knot. So, and they'll put a couple other stitches around, and then finally, what they'll do is their some type of a floppy fundal repair to make sure that they minimize the amount of reflux and make sure that the repair is secure. And here on this last stitch, they've tacked the stomach to the mesh, to the diaphragm, to really try to keep everything in anatomic position. So you can imagine trying to do a procedure like this without optics or the computer helping you do the operation. So this is the first operation that I want to talk about. The second one is from UT Southwestern. This is a robotic Whipple procedure. Now I'm going to show you about 3.5 minutes worth of video. This operation takes about 8 hours to do. So don't go back and say, geez, how come they can do this so fast? Well, the video is heavily edited, but here you can see a huge robot in the room with 4 or 5 different arms. The robotic surgeon is here and they use the endoscopic energy devices to secure the vessels. And here you can see they've transected the pancreas here. They're behind the head of the pancreas. You can see the remnant of the stomach up top. This is actually the chief of surgery at UT Southwestern, letting the surgical oncologist who's trained in robotics do the case while he is the first assistant. And these folks are going to do anastomosis the way you do an anastomosis. It's just they're going to use a little bit different suturing technique. So here you can see they're sewing the pancreatic duct to the side of the jejunum using interrupted absorbable sutures and robotic manipulation, more or less the same way you do it if you did it open, but you've only been able to make 2 or 3 or 3 or 4 small incisions rather than a big midline laparotomy incision. And when they finish their anastomosis, here you can see they don't have that knot pusher. They're actually doing intracorporeal suturing like you do with a laparoscopy or with a robotic procedure here. And they'll finish their anastomosis. I'm not going to show you the anastomosis between the common bile duct just for the sake of brevity, but here you can see how they're physically doing the suturing. And then finally in this procedure, they'll get their jejunum up and pull it up next to the end of the stomach to reestablish the continuity of the GI tract. Anybody in the room worked with the robotic trainer? Played with it? Oh, it's fun to play with. It really is. And you know, you have to do that first and do simple cases before you start doing complex cases like this. And after they've completed their anastomosis with the bowel, they put a drain in, which is kind of standard course, and put it next to the anastomosis in case there's a leak. Then the last case I want to show you is from the Brigham and Women's Hospital in Boston by Dr. Swanson and Dr. Bueno. This is not robotic, but nonetheless, the optics and the instruments you use are advanced technology to make this happen. These guys are doing an esophagectomy. You can see they're working through a window along the lesser omentum towards the hiatus, which you can see here now. And then they're creating this vascular pedicle where you'll find the cardiac vein and the left gastric artery. And before they staple that, they're going to lift the stomach up. You can see the back of the stomach. You can see a very nice vascular arcade with that gastroepiploic artery to make sure that you have good blood supply to your conduit. And then they'll take a tan vascular stapler and staple their vessels. And then they'll turn their attention to a thicker stapler with a purple load to follow along the greater curvature of the stomach to create their gastric tube that then they're going to end up pulling up into the chest. So once they finish their staple lines, they'll take the gastric conduit and see they even have a different kind of suturing machine, one that hands the needle back and forth each time you deploy it to help them more quickly do a suture line. And they'll tack the conduit to the specimen here with a stitch. And once they've completed putting that suture in, they'll tie it. Again, they're using intracorporeal knot tying as opposed to that knot pushing device. And now we're in the chest. You can see them working along the medial aspect of the esophagus up towards the top of the thorax. The pericardium is here on the medial side. We want to make sure we don't get into that. Then they'll work on the lateral side. They want to get close to the vertebral bodies, but not right on them because the thoracic duct runs right along there. And if you get an injury to the thoracic duct, you'll have a chylothorax. Here you can see they've completed their dissection and they're gently pulling on the esophagus and gastric conduit. You can see those tacking sutures that they put in. And they pulled the specimen up gently into the chest. And now they'll take their electrocautery device and divide these sutures. So then they'll have the specimen that will be free in the one operator's hand. And after they completed that, they lift the specimen up. And then using either plain endoscopic scissors or scissors with cautery, they'll transect their esophagus here. You can see the azygos vein running on the chest wall over here. And then once they've completed dividing the specimen from the esophagus, this will be put in a bag and delivered through the chest wall and taken out. And then we take an EEA stapler head and slide it in through one of the ports. And we're going to put it into the lumen of the esophagus. And we're going to do kind of a baseball stitch around that, 2 suture lines to secure the esophagus around the anvil head here. Here you can see the divided azygos vein because they wanted to go a little bit higher up in the chest with the esophagectomy than lower. So this would probably be the upper third of the esophagus since they're above the azygos. One of the things also to remember when you're doing a dissection in somebody who has had previous chemotherapy and radiation especially, those small vessels that come off the aorta that supply the bronchial, the bronchi, the bronchial arteries, those can become very fibrosed. So if you're too close to the bronchus and you devascularize the bronchus, along about postoperative day 4 or 5, you'll notice an air leak and bilious drainage from the chest tube. So you want to make sure you avoid that. So here they're finishing their second round of sutures around the specimen. They've got the lung retracted medially. They're on isolated lung ventilation. And again, the azygous vein that's been stapled so they can get a little further up on the esophagus itself. Now they're going to do their last tie. And then finally, they're going to look around. Everything looks good behind the esophagus. They're going to bring the arm of the stapler through. Once they make a gastrotomy, it's important when they make the gastrotomy to ensure that the gastric conduit is adequately vascularized. And here you can see nice pink mucosa on the inside, which is why they take special care when they dissect along the greater omentum and the gastroepiploic vessel. So they put the stapler head through, they advance the stapler. And you'll see it come through here. And then they'll dock the two. And they'll slowly close. And most of you have probably seen one of these. They twist the dial until it puts between those two lines that tell you that you have a specific thickness of tissue that you need to fire across. And then once they fire, they'll very carefully take this out. Before they close their gastrotomy, they're going to make sure they pass their nasogastric tube down into the gastric conduit, into the abdominal portion of the conduit. And they'll lift up the edges of the stomach wall, and using a thick tissue purple load, will fire across the gastrotomy to close that off. And one more staple fire to finish things. And then finally, they'll take their suction device, make sure everything looks good, and then they'll take this redundant omentum and pull it up over the anastomosis in an effort to try to reduce the incidence of leaks from their anastomosis. And an esophagectomy in 3.5 minutes. Oh, that's incredible. So let's talk for a few minutes about AI and machine learning and surgery. When you really want the robot to do the operation, it's not as easy as just typing in a few keystrokes and saying, take the gallbladder out or do this. You have to, number one, you have to tell the robot everything. It has to be in a granular packet fashion. The robot, even though they have some algorithms to extrapolate, they're nowhere close to there. So the first thing you have to provide the robot with is what's the order of the operation. I mean, and this is one of my criticisms of robotic surgery, because you have to do the order, that you have to do the operation in a specific order every time, because in order to get to the next point, the robot is constraining you with how you can do your operation. Whereas if you have the patient open, you can say, well, this area is too difficult to work on for the moment. I'm going to flip the lung over because I'm a chest surgeon and go look on the other side and kind of work around a little bit. The robot's different. You have to tell it, and it is constrained to this order. Then you have to create a picture for the robot. So when the robot's mind, the robot knows where everything's at. It knows where the gallbladder's at. It knows where the liver's at. You feed it pictures of data that tell the robot what each specific structure is. And then you marry these two, the order of the operation, what everything is, and the most difficult part is conceptually having the robot act on that independently with an algorithm to go and do the operation itself. A very nice interaction between robotics and AI is, however, this ion bronchoscopy device. In the US, we have a very aggressive lung cancer screening program. And the major bronchoscopes will only get you out into about a first or second generation of airway. But with robotic aid and artificial intelligence, you can do a CAT scan of the patient and feed it into the computer. And then using this robotic probe, which is so much slimmer, instead of being stuck only out here with access, you can fish your probe all the way out to the periphery of the lung to get the biopsy you need. And here's a picture of that 3D reconstruction. You do the CAT scan, you feed the CAT scan into the machine does an algorithm that creates this pathway, and then you basically do virtual bronchoscopy. You drive the bronchoscope out through the airway. This is all artificial now. This is not, you're not seeing this with your eye. And then you can target the nodule and advance the biopsy forceps into the nodule. So this is really a wonderful application of artificial intelligence. You're in charge, but you're given so much more data that you can work with. And then just briefly, can we do this? Yes, 2 years ago in science and robotics, the folks at Johns Hopkins took a porcine model for pigs and programmed into the robot how to do bowel anastomosis with minimal input from the surgeons itself. So it's happening, it's slowly evolving. It's just not going to be operating on a human anytime soon. So AI in surgery, just a quick summary of this, tends to be better suited to analyzing data points and predicting complications rather than just you handing the robot and say, do the operation. It certainly has found a niche in evaluation of lung nodules, not only in biopsying them, but in going through all the various reports to codify your level of suspicion for whether they're malignant or not. And the robot can scan millions and millions of documents in a brief period of time, extract those data points, and feed them to a human being for further processing. The only catch is that data has to be an Epic or Cerner or some type of a health information system that has granularized that data for the robot to analyze it. The robot's not just going to look at the chart and go, I wonder what they meant by that, and I'll look into it. The robot can't do that. So now, in the last couple minutes, the fun part of the talk, can knowledge be unlearned or forgotten? This is the Pantheon in Rome. It was originally built about 25 BC. Pantheon, all religions, so all gods were welcomed here. So when the Christians came and took over Rome, they didn't tear the temple down because everybody's God was welcome here. And it is truly an incredible place to be in if you ever have the privilege to go. I mean, it's just absolutely stunning, but most stunning is the ceiling, is the roof of the Pantheon. It's a perfect sphere, which basically corresponds to the globe. Now, how did we know that? I don't know, it just happened. And here's the layout. Originally built in 27 BC, destroyed by fire twice. The building you saw there was built at about 126 AD. 2,000 years later, as of today, this building still has the largest unreinforced poured concrete roof in the world, 2,000 years later. So when the Renaissance came around, the Great Awakening in Europe, and people said, well, we want to build grand churches and grand palaces. So they hired Filippo Brunelleschi, who was an architect and an artist from Florence, Italy. He was extremely impressed, and he went looking through all of the stories. You know, how do you do this? It was gone. Nobody knew. So what did Brunelleschi had to do? He had to do detailed drawings of the building. He actually went in, and you can see the two spots where he cut a hole in the building to figure out what the building materials were, to then rediscover these engineering meridional forces and hoop forces of dome, and how you design the dome with progressively lighter materials. You know, all of this stuff forgotten, 12 centuries, had to be relearned. And after he did about 10 years of work trying to figure all of that out, he was able to create this incredible dome in Florence, Italy. But you think the Romans were smart? They were nothing. The ancient Greeks, 1,000 years before them, and Syrians knew how to do this all already. So this was pretty much common knowledge at the time of the Roman Empire, but had been forgotten over the years because nobody did it. So are you starting to see where I'm going with this, with technology and medicine? And this is his masterpiece. So now let's talk for a few minutes about Air France Flight 447. This is a really tragic example of what happens when you become over-reliant on technology. This was a flight in June of 2009, a very nice, you really wanted to have this route if you were a pilot, from Rio de Janeiro to Paris. So the plane takes off, an Airbus 330, perfect weather. And then there's a radar dead zone where there's really no radar coverage between South America and Africa and then up to Paris. So the plane disappears. It takes them 2 years to find the flight recorders at the bottom of the ocean and figure out what happened. The captain had 11,000 hours of flight experience. The first officer had only 2,000 flight hours, and most of those were using the simulator and the computer robot. And the 37-year-old first relief officer had only about 6,000 hours. So you can see there's a big generational difference between the training of the first officers and the captain. The Airbus 330, one of the safest planes out there. It's got so many computer systems in it, it prevents you from flying too fast or too slow, climbing too steep, diving too sharp, rolling to one side or the other. I mean, the computer just flies the plane for you. So the first officer sees this growing band of thunderstorms, this recovered from the flight recorder, on the radar right at the equator, which is common. So they thought, well, the worst we'll see is some turbulence or a little bit of icing. And they saw bright flashes of light in the cockpit. And the pilot, 58-year-old, has to take his mandatory rest. So he leaves around the corner to his rest area, leaving the 32 and the 37-year-old first officers to fly the plane. So they're flying through these ice crystals. This is a pitot tube, which you probably maybe have seen on an airplane. It's an airspeed sensor. It measures air coming in and a static column of fluid to give you calculations like the airspeed, the Mach number, and the altitude. But if it becomes clogged, it doesn't work. So then the computer that's relying on the information from these 3 pitot tubes has a problem. So the pitot tubes became clogged with ice faster than the built-in heaters could melt it. So all of a sudden at 2:10 a.m., the 2 co-pilots are sitting in the cockpit. One's listening to French music, the other's reading a book. It's perfectly quiet. All of a sudden, all the bells and whistles go off. The plane's autopilot disengages, turns the engines down, all the alarms start going off, and these 2 guys are just like deer in the head. What is going on? So the turbulence causes the plane to roll a little bit. The one pilot, who's panicked, just pulls back on the stick. Now they're at 35,000 feet. So for those of you who aren't real big on aerodynamics, the air is pretty thin at 35,000 feet. But when you're on the ground, you can climb at a 30-degree incline. But if you're that high up and you try to climb at that, you develop this stall pattern where you get to a point that the plane just starts to fall out of the sky. So the first officer reduced his rate of climb, but turned the engines down. The captain is frantically summoned to come back to the cockpit because the 2 co-pilots don't know what's going on. The airspeed indicators have actually returned to normal, but these pilots are in such a panic. So the one says, I don't have control of this airplane. And the captain returns that the 2 guys are in complete confusion. He's trying to figure out what is going on here. Well, unfortunately, the last words on the flight recorder from the captain were, okay, 10 degrees pitch up. And then 2 seconds later, the plane slammed into the ocean at 108 knots. And for those of you who know aviation, you have to be at about 160 knots to get a commercial airliner off the plane. So what happened? Why did this terrible tragedy occur when you had all of these computer built-in systems to keep you safe? The average A330 pilot will hand fly the airplane roughly 4 minutes, 4 minutes out of every flight. So that's a 6-hour flight. The pilot is actually flying the plane for 4 minutes. And the pilot only flies 2 to 3 flights a week. So they're actually flying a plane. And every time you hear pilot, think of surgeon. And every time you see airplane, think of operating room. If you're a surgeon that's only actually operating for complex procedures roughly 4 minutes out of the operation, how are you supposed to know when something goes wrong what you're going to do? The majority of the time flying this airplane is spent dealing with the automation, watching the computer, making tactical decisions about when you're going to land. But physical piloting skills, again, surgical skills, are developed with extensive training, there's no automation. You just have to do it with your hands. You have to understand the operation. You have to understand the aerodynamics because you have to develop an intuitive sense of how to manage patients. And if the patient had been in the cockpit, most likely the alarms would have went off. He said, "What is going on?" But the plane's not dropping. Everything's fine. He probably would have just said, "Well, I'm going to do nothing. I'm just going to think about this for a minute and figure it out." The analogy I use is when I get a panicked call from the nurse in the intensive care unit, "Dr. Podbilski, come quickly. The alarms are going off on the patient. The blood pressure is low. The heart." Okay, so I go running. I go in the room. The patient's sitting in a chair reading the newspaper. "How you doing?" "I'm doing pretty good." Okay. Then I'm looking at the alarms. I'm looking at the patient. I'm going, there's something wrong. Am I confident that the information I'm getting is accurate? And the same thing happened that resulted in this. When you over rely on technology, and then all of a sudden you have to do the operation or you have to fly the plane and you're not prepared to do it, you crash and burn. So when considering AI and advanced technology, I, as a surgical educator, am often amazed by my trainees who can do a laparoscopic cholecystectomy, but if they get into the common bile duct, they're sunk. They put a drain in, transfer the patient to the university because they don't know how to fix the common bile duct injury. Or gynecology trainees who can do a robotic hysterectomy, but if they get an enterotomy, they're uncomfortable doing a mini laparotomy to repair the enterotomy and then finishing the procedure open. Cardiothoracic trainings who can do TAVRs, but if their patient is constipated afterwards, they're clueless. They're clueless what to do for the patient. It's that silly. And then finally, people who know all kinds of stapling technologies, but can't do a simple 2-layer hand-sewn anastomosis. So the take-home point is, are these newly trained surgeons who rely on AI, are they going to rely on AI to manage their complications as well? All of this stuff we do minimally invasive is all predicated on the understanding that we need to know how to do this stuff open. So for the last 5 minutes, just some attitudes. In the US, 60% of Americans are uncomfortable with AI providing their healthcare. Fewer than half think that artificial intelligence are really going to improve outcomes. More are concerned that healthcare providers are adopting AI too fast rather than too slowly. They do think in the US that this will reduce medical errors, but the greater concern, as Professor Minopo pointed out, where does that leave the patient-provider relationship if you have a machine doing the thinking for you? Will it help racial or ethnic bias? Some think it will. Some think no. If AI is programmed by people who have an intrinsic bias, AI is going to have an intrinsic bias. And 2/3 say they don't want their AI giving them pain medication. And almost 60% of Americans say they do not want AI. They don't mind robotic surgery. They kind of like robotic surgery, but they don't want AI doing their surgery. They want a surgeon standing, even if the surgeon isn't at the table, they want a surgeon at the console doing the operation. So the last slide, just a few closing thoughts. When AI replaces rather than aids our decision-making as surgeons, we become helpless slaves to an unpredictable and often unreliable master. AI can definitely help you do mundane tasks better, but when the things in the operating room or in the cockpit of a plane go off the rails, the machine just checks out and leaves you in charge. And boy, you better be ready. And then the last thing I want to say for 1 minute is the public robotics. There's this notion in the US that if you don't have your surgery done robotically, you are just not getting good quality health care. I mean, the robotics company almost brainwash people with their advertising, and surgeons especially, that if you have to do a gallbladder open or something, you're a bad surgeon because you should be doing it with the robot. Robot is a tool. It's a great tool. If you have access to it, utilize it. And if you don't, do a good job for your patients. And that is, that's the end. I thank you for your attention.
Thank you very much, Prof. Francis. So we will have parallel session with the online session. Yeah, so for the on-site session, we will have Dr. Aga Patianagara. She is a assistant professor with Erlangga University, and is also attending in oncology surgery in Erlangga University Teaching Hospital. So you will have 15 minutes. Thank you.
Good morning, Professor, seniors, and all of the participants. My name is Dr. Wara. I'm a plastic surgeon. So right now, we will start our online session. So the first speaker is Dr. Nina Irawato, surgical oncologist from Mayapada Hospital, Surabaya, that will present about oncoplasty and reconstruction in oncologic surgeon. So time is yours. Thank you, doctor.
Hi, everyone. Thank you so much for the invitation. Can I be clearly heard?
Yes, Dr. Nina, you are clearly heard and your presentation is already seen.
Okay, so I'm just going to start because I believe I only have 50 minutes, correct?
20 or 30 minutes is okay, Doctor.
Okay, excellent. Good morning, everyone. My name is Nina. I've been grateful to be invited in such meeting like this and to talk after Dr. Francis. I feel that my presentations probably cannot actually compete to his slides because, of course, I'm going to talk about some updates in head and neck reconstructions, but as Dr. Francis says that to be able to see the futures with all those technology, we should never forget about all the simple things that we used to do. So I'm going to change a little bit my title because I'm actually working for head and neck unit. So it will be about oncoplasty for head and neck cases. I have nothing to disclose. If you talk about oncoplastic surgery, then we know that we usually use this term to define some kind of surgery that belongs to breast or breast conserving treatment. But then I found out when I made this slide that there is another article which is just published in 2020 that oncoplastic surgeries also can be used for head and neck cancer. It's just because the term of oncoplastic surgery is actually a combination and integration between the theory and technology. And then we try to plan the reconstruction after we're doing ablative. And then that's how we're trying to do some immediate reconstruction for any surgical defect after the ablation surgery. And then, of course, when we talk about reconstruction, we should never forget about the step ladder that we theoretically use it since many, many years ago. And according to this ladder, we are taught that all the reconstructions should follow this step from the simplest one to the complex one. But as we have more cases, more complex cases, more advanced cases, and more technology, then we kind of like adjust this and modify it a little bit. Of course, it depends on the institutional itself, the skills of the operator, the advance of the cases, the resource that we have. Then only we can do so many options, and then we can choose which one that actually can suit with our cases. When we talk about the step of reconstruction, then we, of course, initially we have to do some wound analysis. That consists of what tissue types that missing and how much, which anatomic boundaries that we enter, what relationship and the structures neighboring the defect, and what functions that actually diminish after the ablation. And from those considerations, then the surgeon must select the right procedure for the right patients at the right place and at the correct time as well. So when we talk about reconstruction, of course, we're not going to discuss about some skin graft and those things. We kind of like, we routinely use a flap, and we know that there's so many type of flap here. We start with the local flap. We all know about the random flap, the axial flap that we usually use for any small till medium defect. And then we also have pedicle flap, which is more medium, and then big size of defect up to free tissue transfer itself. And for flap classifications, we also have the type of flap according to the flap content, cutaneous, fasciocutaneous, musculocutaneous. I'm not going to go through all these details. I'm sure that all the listeners already know about this. And then it can be advancements, which consists of transpositional and rotational flap, interpositional flap, as well as interpolated flap. All the residents and all the speakers here know about all the simple flaps, such as below rhomboid and Z-plasty that we usually do for any small defect in the face. And then that's why we have flap classification as a local, regional, and distant flap. And the goal is actually we just need to make sure that we have adequate and appropriate color of between the flap and the defect, adequate thickness, and then we try to preserve any sensory innervation, if possible, with sufficient laxity. When we talk about local flap, we know that it has linear configurations, and usually we use this kind of flap for any kind of small defect that if you close it primary, it will be too tight, and then it's probably not too aesthetic enough, and that's why we can use local flap in this sense. There's so many examples that we can use in head and neck, including the buccal sliding flap, advancements, as well as buccal fat transpositional flap. Rotation flap, we usually do for any kind of skin cancer. We know that for any defect in the nose, forehead flap is one of the best flap, local flap that we can use. The most popular one will be Rintala flap that usually we're doing some kind of a pedicle flap with angular and supraorbital arteries. And then we use palatal flap, probably is not too clear in this left inferior side of the slide, but it's actually, this patient is post regional flap, and then we found out that there is a defect around the palate area, and that's why we put palatal flap and we rotate it to close the defect. There is a buccinator muscle island flap, which is supplied also by facial artery that can be used for any small defect, either in the floor of mouth or any palate, which can be rotated easily if you have such defect. This is one of the cases that we combine. There are two local flap that we use here, which is lasorabian and fem flap. This is not head and neck cases. I mean, like this is not head and neck oncology cases. This is actually patient with a severe trauma, and then she lose a lot of labial tissues, inferior labial tissue, and then we try to reconstruct it with a fem flap as the inner layer, and then nasolabial as the outer one. Transposition flap can be used for the nasal tip, alanasi, and then lips as well. For example, rhomboid and limber flap that we usually do for any kind of a small skin cancer defect on the face. Interpolation flap is another things that we usually do for any kind of skin cancer, which is including paramedian forehead flap for any kind of a small defect. Lateral forehead can be used for small and medium defect, which usually happens in the face area. And though it's not too aesthetic, it can be seen in one of our patients here. But this is actually this is our plan B whenever we have some kind of a big defect, and then at some point we cannot close it with free flap, or there is something wrong with the patient, probably with a severe comorbidity, then lateral forehead flap can be a choice for such situation. Abby flap, as we know that we usually do it for lip reconstruction, inferior. And then tongue flap can be used for any type of palate defect, buccal defect, or some labial, as well as floor of mouth reconstruction. If you talk about small defect, then those flaps that we just discussed before can be used easily. But since we're dealing with a lot of advanced cases, head and neck cases, and then we're also dealing with any salvage cases, the patient also have long waiting list of radiation. Hence, we have to tackle a lot of recurrent cases. Then those flaps cannot be used in such conditions. And therefore, we have to increase our skill to be able to do regional and free flap on those patients. As we know that regional flap is usually indicated for any medium till large defect that probably is not suitable for any type of free flap reconstruction for any reason. And the disadvantage is probably that sometimes the color match and texture, as well as donor morbidity, doesn't really match with what our expectations. Like as I said before initially, that the reason for we doing reconstruction, if we're trying to replace like with like, as well as we're trying to fix all the texture and the color mix match. For examples, that PMMC is one of the workhorse regional flap that we usually do in head and neck. And we can see that it's very robust flap. It's easy to harvest, and salvage kits, it's one of the best option actually. And the reason why I like PMMC is because if you're doing LD flap, for example, we have to change the position. While PMMC, we can do it with ablative. So it's kind of like we can save the time as well. And then it's just quite good as a robust flap. DP also can be used. What we probably don't like with DP is it's not as thick as PMMC, but it can be because it does not contain really muscle. So we usually don't do DP unless we kind of like making it as an outer layer reconstructions. So it can be used as a double flap. For example, like this patient, he had recurrent sarcoma of mandible with M1. So this was like palliative surgery. I did it because the patients keep bleeding from the side of the tumor. I don't think that, although it's probably indicated for double free flap, but looking at the situations that time, I decided to just do a double flap for those patients. The patients died 6 months after the surgery because of M1. And in this case, we use the combination of PMMC and DP flap, where the PMMC will be the inner layer and the DP flap will be the outer layer. As I said, that DP is quite thin, and so it's better to put DP on the outer side of the PMMC flap that we use. And then we also have a sternocleidomastoid SCM flap. We don't really use it unless we don't have any other options. We can use it even for tongue reconstruction. We also can use it for any parotidectomy or trachea reconstruction. I use it to cover my plate after the fibular flap. And then this is the LD flap. As I said, that LD flap is also robust. The weakness of doing LD flap for head and neck reconstruction is actually just because we have to change the position like multiple times, and it's kind of like wasting our time for reconstruct, to be honest. But there is one patient that last times, I think 2 months before, also with the recurrence palliative cases for sarcoma of the mandible, and then we use osteo LD flap where we also included the 10 ribs with the LD and serratus and some intercostal muscle to make sure that the ribs that we put can replace the mandible segment that we remove, and then the LD as the inner and outer layer of the defect. And then there is also buccal fat flap that we remove the buccal fat pad from its place, and then we remove it to the place of the defect. Usually is around buccal or probably some palate. The weakness of doing it is because it's not bulky, so only small and medium defect can be covered by this kind of flap. And the second thing is buccal fat pad tends to have granulation after surgery. So when you have granulation after the surgery, then you're questioning whether this is recurrence cases or this is actually the buccal fat that doing some kind of transformations or change of its structure. So we rarely use a buccal fat pad. Platysma flap also can be used for tongue reconstruction. We also have segmental flap. It's not really popular, although it's very easy to harvest. The reason why we're not doing segmental flap in some cases is because to remove segmental flap and then put it in defect, usually intraoral, it's kind of tricky because we know that in segmental flap, there is a level 1A node that should be included when you're doing this flap. So definitely no for tongue cancer cases, because let alone that we probably can have recurrence of the node on the flap intraorally, and I think that's something that we're trying to avoid. So segmental flap, although it's popular, although it's easy, for head and neck cancer, especially tongue cancer, it's not really advisable to do. Platysma flap, this is a nice flap for small and medium defect, especially for tongue lesion. You can place it anywhere, even for the floor of mouth, the cheek, RMT region, or even to lining the lower lip. So coming to the free flap, in our institute, because we're dealing with a lot of oral cancer, mandible, then of course the flap that we usually have is the soft tissue ALT and radial forearm. We also have latissimus dorsi flap. For bone reconstruction, we mainly doing fibula. This is one of the flap that we usually do for the soft tissue reconstruction, especially for the tongue. Radial forearm is so gorgeous to be put after hemi or subtotal glossectomy. If you need more tissue to be reconstructed, then we can go for ALT. And the reason why ALT is one of the best options for medium to big flap is because it's quite robust free flap. You can have a very nice pedicle. It can be used for any large tongue defect as well as parotid. And even with the parotid area, you also can do some kind of facial reanimations. So with one flap, you can do a lot of things with different function. LD flap, free flap, we usually do it for any big and very big size of scalp defect. We combine it with skin graft. Here we did it for our recurrent sarcoma patient, MPNST. The patients, we did it, I think, in 10 hours. The reason why LD free flap is quite challenging is because, as I said, that to do LD regional flap itself is already quite challenging because you have to change the positions multiple times, let alone if you're doing LD free flap where you need to close the wound first and then you have to put it the patient's at supine position and then do anastomosis and probably have to come back to another position. So it's kind of like challenging. You cannot do it simultaneously, and that's why most of the time LD free flap requires more time to harvesting and doing reconstruction. Jejunum flap usually for esophagus reconstruction. I feel that we don't really use it here because instead of jejunal flap, although it's a good flap for esophagus, especially through and through reconstruction, but to compare it with gastric pull-up, we feel that it's better to do GPU instead of jejunal flap because jejunal flap has a very, very restricted ischemic time. You have to have like a very, very good and solid like 2 teams reconstruction because you have limited time for doing anastomosis and other suture. Fibro flap is a very gorgeous for bone reconstruction. We use it many times. Scapula free flap also can be used for some small segment of bone reconstruction. It can be used for maxilla and then mandibulectomy as well. Iliac crest, usually we do it for lateral and hemimandibular defect. And because we're trying to improve our reconstructions, then we know that other part of the world, they're already doing CAD/CAM where the computer actually assisted to manufacturers and at the design of the mandible. And the reason why we're doing it, the goal is the same. We're trying to find some precisions in all the reconstruction that we do. And especially for maxilla and mandibular, we really need a precise bony reconstruction. And one of the things is by doing CAD/CAM and 3D technology. So with 3D technology, we can actually plan where the defect is. We're gonna plan where we're gonna cut the segment, and then we're gonna plan where we should cut the bone and then where we're going to place it. So everything is already beforehand before we start the surgery. And as I say that by doing all of this stuff, not only the precision that we targeted, but we also try to shorten the length of the operative time of surgery, where it's not only increase the cosmetic result, but it also decrease the complication of long duration of surgery. And of course, by doing CAD/CAM and 3D, we have to start it with doing virtual surgical planning. And we already have some kind of collaboration with our technical unit from institutional technology of Surabaya. So I have my own team where we always have a meeting about this, that my engineer know which fibula that I'm going to do, which anastomosis of the neck that I'm going to have, as well as how many segments that I plan to have and which segment of the fibula that I'm going to have. So everyone knows like how many segments of this patient, what we're going to do, where we're going to cut the patients between us, the free flap team, as well as the engineer. So for example, that when we have a case and then we're doing a CT scan and then we're going to change it to the decom file and then they're going to replace it. And then with the computer assisted planning, we can actually understand that which size of the mandible that we're going to cut and how much is the margin from the tumor itself. And then the operating plan will be made by the engineer based on their computer algorithm. They have their own software. The software that we usually do and we usually have is ProPlan, CMF. And then from there, we're gonna make a cutting guide. So the cutting guide is the 3D technology where we actually place it in the segment that we're going to cut. So you can see that the white color there, that is the cutting guide that we use. We place it, we fixate it with a screw, and then the ablative surgeon will cut it exactly on the cutting guide. And then the second pictures is the cutting guide for the fibula. So the fibula that's already been planned before the surgery, we already know where to cut it and then where we're gonna have the segments and how much segment we need it. And then based on that, we place it intraorally. And then this is the patients after 3 months of surgery. This is ameloblastoma case, so he does not have any other adjuvant treatment. We're just gonna follow him up. Can see that the right cheek still a bit swollen, but it's still 3 months, so I think it's we're allowed to observe anyway. He's quite happy. There is no complications, significant complication. He had sepsis after the surgery, unfortunately, and thankfully he survived from that condition. So we move from bony reconstruction with CAT-CAM, which is on the right side, probably on the left side on your screen. And then the left side, it's all ameloblastoma and osteosarcoma case. I did it manually with my team. And yeah, we feel that the CAD-CAM, the 3D technology, and the VSP planning really help us in managing all of this advanced reconstruction. But of course, we dream big. We want to have those joy in a day that other third countries already done. We want to have a case where we can do ablative reconstruction and dental rehabilitations in one day at the same time. It's a big dream, but I think we all can have dream, right? And then we come up with the more update reconstruction where we use extended reality. I haven't talked about AI here. I think it's still quite far away. But even now, we already try in head and neck to incorporate this extended reality into mandible reconstruction and maxillary reconstruction. We know that virtual reality, we know about augmented reality, and of course, mixed reality. And this paper actually came out from my institution in Australia, where they did VR for mandibular reconstruction. We know that virtual reality and augmented reality is very, very popular. And most of the time, it will be used by the dentist or the prosthodontist overseas. So they already done this for dental rehabilitation. They already done this for placing the screw. And then we move forward of how to incorporate all this technology for mandibular reconstruction. Tim Manzi here, he actually did this research. He makes some kind of virtual reality for mandibular reconstruction, and he tested all those 15 surgeons and to ask them like what they feel about it. And most of them says that it increased the level of confidence of the surgeons before the surgery, which is, it makes sense because before the surgery, you already know where to cut, and then you also can tackle if you have some problem intraoperatively. So I think that's the reason why many of the surgeons feels more confidence after doing it virtually before they enter in the operating room. And also, we already know that augmented reality, in theory, is already been proven by cadaveric study and some other published study that, yes, it can be used for fibular osteotomy. You can see the QR code that they place around the fibular bone is actually to register the fibula. So they have to register the fibula. Imagine that you are a Superman with your Superman camera on your face. When you're doing surgery, you don't really need to see the fibula. You can register it with your camera in your headset, for example. So that's the reason why they put the QR code there, is to register it virtually. So there's so many published about CAD-CAM and augmented reality for fibular harvesting. And that is another goal that we're trying to achieve. So we have a joint research between University of Sydney, University of Indonesia, and our institute as well at Sutomo Hospital. We're trying to find out, which is in still a phantom model, the application of virtual reality for mandible reconstruction, and then we use the augmented reality to cut the fibula. It's still ongoing, so probably next time in the next meeting we can report our progress. last but not least, the summary, the take-home message is oromandibular reconstruction can be challenging with a lot of options, but it's also proven to be reliable and successful with the excellent long-term outcomes. And although we are living in the era of microsurgery, as Dr. Francis said, that we should never forget the past. The past is about the history, the knowledge, the skill of doing local and pedicle or regional free flap. So those skills should always never be diminished in surgical skill that we have. And of course, the new pathways, the robotic, the AI, the image, the digital skills that can be used for mandible reconstruction, it's actually an opening door for the more precision surgery that we can have in the future. I think that's it. Last but not least, this all my team. I'm so grateful to have them, although probably they're not here. Some of them will be here in the Zoom meeting. Thank you so much for this session. Thank you.
Thank you, Dr. Nina, for your insightful presentation and a lot of interesting cases. So, so maybe because of due to time restriction, so maybe only one question that can be asked by the participants. So if there is a question, you can raise your hand or put the comment, your comment in the comment section. So as a summary, so we have to, based on the what Dr. Nina say, that we first we have to identify the defect of the wound that we have to close, and after that, the surgeon must select the best option based on the step ladder pattern concept for the reconstruction. Is there any question maybe from the participants? Okay, because of the time restriction. So thank you so much, Dr. Nina, for your presentation. It's very insightful and interesting about the reconstruction of the oncology cases, especially for the head and neck region. So next, we move to other presenter. So the second presentation is from Dr. Vikas Jain. So he is an urologist, robotic and kidney transplant from Manipal Hospital, Dwarka, New Delhi, India. So nice we can meet you. So you can start your presentation. So there are 20 minutes presentation and 5 minutes for the question. Thank you so much, Doctor, for your time. Time is yours.
Hello, I'm audible?
Yeah, clearly I can hear your voice, Doctor.
Okay. So I'm Dr. Vikas Jain, and I'm very thankful for the International College of Surgeons at the Indonesia chapter to give me an opportunity to present the role of robotics in surgical oncology. I'm not in Delhi, I'm in Nasik, this SCG Cancer Center. It is dedicated center for cancer surgeries, especially the minimal invasive surgeries, where we do the laparoscopic and robotic surgeries both. So today I'll talk about the robotics in surgical oncology for systematic divisions from head, starting from the thorax and esophagus and reaching up to the prostate. So why robotics? What's robotics? Robotic surgery is a novel technology in minimal invasive surgery, where it just started in 2000 by the FDA approval. And initially it was started in prostate surgeries and uterine surgeries, hysterectomy. Then it came into the general surgical procedures. And recently it has been started into the minimal invasive cardiac valve repair surgeries as well. So, but I'll talk about only the oncological principles and surgical oncology. So what is the advantage of robotics? First thing that it gives a three-dimensional views with a greater magnification in comparison to laparoscopy. Although in laparoscopies, 3D vision also have been come in market now. The stable operating field is the best advantage in robotics, where we see that we are not dependent on our assistant and which keeps on moving. So it aids the surgeon to visualize the complex anatomical area and make a finer dissections with a greater stability. Another is enhanced dexterity and the endorist movement. We get the 360-degree movements, and we can dissect much better and easy way in critical areas, where I will demonstrate in different small video clips. Then the dissection, especially the lymphadenectomy, is better, and scaling of motion and improved ergonomics, which makes our procedure very safe and with improved accuracy. But what are the challenges in robotic surgery? We have first the anesthetic challenge, because there are the extreme positions, and patients lies in different extreme positions where the anesthetists are many times are not comfortable. And second is we don't get the lack of haptic feedback. We are lacking the haptic feedback there. We don't feel how much is the resistance in the tissues when we are dissecting or we are cutting through the tumor. And the most important for developing countries is the cost factor. Though after patent has been over, there are multiple robotic system in the market, so the cost also is getting decreased now. And the another last most important is availability. Robots are not still available in all the hospitals in any country. So now I come to the system-wise divisions. First, I'll talk about the esophageal squamous cell carcinoma, where there was different studies was done with, it is a robotic assisted versus the conventional laparoscopic surgeries for esophagus, which included the squamous cell carcinoma in the first settings. And this REMI trial shows that they achieved a shorter operative duration. Though in the initial days of robotic surgery, the major disadvantage of robotic was a longer operating time, because all the surgeons are in learning curve. But now they have achieved a shorter operative durations in comparison to laparoscopy, and it definitely gives a better lymph node dissections, better lymph node yield in the patient who have even received the neoadjuvant therapies in esophageal cancers. In view of the blood loss and conversion rates, there was no statistical difference in REMI's trial for robotic versus laparoscopy. Second is the ROBO2 trial, which is still undergoing and the results are awaited, which includes the primary outcomes of the total number of resected abdominal and mediastinal lymph node specified per lymph node station. Because in oncology, the lymph node dissection is the main outcome which we used to see as a quality of the surgery. This is the third, if we come for the gastrectomy, the robot-assisted gastrectomy, whether it is Boone or Bain, if we see this chart, initially, we see the laparoscopic and robotics. When we started studies in 2009, there was no significant difference. But when 2009 to 18, definitely the operative time was still longer than the robotic surgery, laparoscopic surgery. But there was significant reduction in the blood loss, and lymph node yield was improved with time in robotic surgeries. Another study is the Mona Lisa study. It is the only study which again is in process, and we will get the results in 2031. It is a randomized control trial which will verify the superiority of robot-assisted gastrectomy over the laparoscopic surgeries for the Japanese patients in gastric cancer. So in this Mona Lisa studies, the incidence of all post-operative complications of grade 2 and higher will be considered. We will see the recurrence-free survival and overall survival when outcomes will be published in near future. The rate of robot-assisted surgeries, how much is completed, how much is the complication rate, and the completion rate of the surgeries without any conversion will be discussed in Mona Lisa studies very soon. The laparoscopic gastrectomies overall has some drawbacks. What we see as a motion restrictions, and there are difficulty in spatial perceptions. And the robotic gastrectomies overcome these drawbacks because they have the articulated forceps, articulated instruments, and most important, these are the tremor filtering capabilities, which makes the surgeries very finer and more precise. And we can see the high resolution 3-dimensional images in robotic surgeries. Other than that, what is being studied in the Mona Lisa study is very important is ancillary analysis of surgeon's fatigue. Because if the surgeon is comfortable, surgery will be comfortable, and definitely there will be a better outcome if the surgeons operates with a comfort level. So this study will analyze the surgeon's fatigue level also, and the post-operative patient-reported outcomes, including the cost effectiveness in these studies, will come soon. So this is a meta-analysis of robot versus laparoscopic gastrectomy techniques in gastric cancers, where we see in 2009 to 2012 in different studies. Definitely, we see the initially operating time is much higher in laparoscopic surgery, robotic surgeries. But if we see in the blood loss, robotic surgeries 92 ml, 156 ml. In similar pattern will be seen in all of the studies. Like this is the 91, it is 147 ml. Again, comparative to all studies, blood loss is much lesser in robotic surgeries. Again, and with that, lymph node retrieval also is much higher and much better initially it was almost similar, but with time, robotic surgeries gives much higher lymph node yield. So this is a small video where we can see how clear and how better lymph node dissection can be achieved in robotic surgeries. This is the gastric mobilization in the esophageal surgeries, esophagectomy, where we can see that this lymph node, these vessels have been delineated, common hepatic artery, splenic artery, and the coronary vein with left gastric artery is visible on this triangle. This is the Baines triangle of the vessels where the lymph nodes can be retrieved very fine way without any significant blood loss. Each and every fiber is visible. So the vessels are getting denuded. And the most important thing that the small capillaries which are supplying to the lymph node, which causes a lot of blood loss, which are not very well visible when we are operating, but when we see the mops and overall blood loss after the surgery, then we come to know that there is a significant blood loss. This blood loss can be reduced when we are getting much clear and visible vision. So in this we can see that when we are using this articulating instrument in robotic surgery, we can dissect all around the vessel and we can denude the vessel completely, removing all the fatty and lymphatic tissues. So this circumferential dissections of vessel can be achieved much better in robotics. And then this is the left gastric artery ligation. This is the gastric omentum division for the complete stomach mobilization. That vessel sealer we rarely use, only on some places, and most of the dissections we do with monopolar and bipolar in our robotic surgeries. Only for the major named blood vessels we may use the vessel sealers. So this is the omental bursectomy. Again, this is the common hepatic artery clearance. All the lymphatic tissues has been lifted off and arteries has been cleared of lymph nodes. So in this way, we can get the much better vision, three-dimensional movements, and we can achieve much better clearance. Now I'll come back to the thoracic part, the lobectomies. Lobectomies, there was no statistical significant difference was observed in terms of hospital stay in the both groups in the VETS versus the robot-assisted lung surgeries. So I'm not much favor in laparoscopy versus robot, but definitely in comparison to the open surgeries, minimal invasive surgeries much better because it gives a very small incisions. It causes very less pain in post-operative period, and recovery of the pulmonary functions will be much better when we go for minimal invasive surgery. So this is the comparison of the robotic versus laparoscopic or VETS in lung surgeries or the lobectomies. We can see that there was a higher surgical time in robotic surgery, but in comparison to the post-operative drainage, we'll see on the day one, VET surgeries is much higher. Day one, day two, drains are much higher volume than comparison to the robotic surgeries. Probably because much better vision and much better control of lymphatics and other tissues, less inflammatory response in robotic surgeries after. Actually, it is a more minimal invasive than the laparoscopic minimal invasive surgery. If we see the complication rate, in the group A, the robotic group has 32% complication rate versus the VETS is 46%. There are more air leaks in laparoscopic surgeries. More cardiac complications were observed in laparoscopic group. While the overall survival and oncological principle, it was almost same in both groups. So it was concluded that robotic surgeries burdened by the higher surgical cost, it constitutes a valid alternative for the VETS if there is no cost issues, and it determines a lower inflammatory insult with the consequent reduction in pleural effusions, or we can say the post-operative drainage. It causes less post-operative pain and cardiological comorbidities for the patient. It determines the shortening of hospitalization as well. So there's a small clip of lobectomy. If we see, I'll not go for the whole clip. So these are the port positioning, and if we do the lobectomy, lower lobectomy, we can directly approach for the middle fissure. This is the middle lobe and this is the lower lobe, and we are going through the fissure approach. This is the oblique fissure. We can see and we can have better control. If we see better, we can have better control without any significant blood loss. We dissect along the oblique fissure. Even if we do the vessel dissection part in robotic and laparoscopy, and if there is a cost issue for the staplers, we can, after dissections with the same opening what we are going to use for the specimen retrieval, we can just have a tie around the vessels after dissecting all around. But in this case, we have used the staplers because there was no issues for the cost factor, and we have taken all the vessels by the Hemolock clips and the staplers. Now I'll come to last. This. So this was the post-operative scar or the size of the incision where we have removed the specimen, and definitely the smaller the incision, lesser is the pain. Then I come back to the rectal cancers, rectal surgeries. This is the ROLAR randomized clinical trial, and it has concluded the result that conversion rate was 8% for the robotic surgery in comparison to the laparoscopic surgeries, where the conversion rate to the open is 12%. Now I like to demonstrate the superior hypogastric plexus, which can get damaged when we are going for the IMA dissection. So inferior mesenteric artery dissection is very important in colorectal surgeries, the anterior resection and the left hemicolectomy, where we are taking the inferior, for the oncological point, we take the inferior, mesenteric artery at the root of the, at the origin of this inferior mesenteric artery. So it is the site where exactly the nerves get also damaged. So this is the left side and this is the right side of the superior hypogastric nerves, which definitely need to be preserved for their erectile dysfunctioning and other bowel and bladder movements. So these nerves has to be preserved when we are going to do the inferior mesenteric artery dissections at the origin. We get the better lymph node yield and we still can preserve the nerves without any dysfunctioning of their functions. So this is important. Then robotic versus laparoscopic minimal invasive surgery for rectal cancer. There is a meta-analysis of randomized control trial, and aim of this study again was the safety and efficacy of elective rectal dissections by the robotic surgery in comparison to laparoscopy. And it was concluded that the perioperative outcome of oncological process was almost similar, but the robotic surgery patients have the lower rate of conversion to open surgery, and surely the operating time initially is higher for the robotic surgery. There is another robot-assisted versus laparoscopic surgery for rectal cancers phase 2 trial, where the rectal cancers stage 1 to T1 to T3 were included, enrolled, and they were randomized both for the 1:1 for laparoscopic and robotic surgeries. All patients were have undergone the pre-operative chemoradiotherapy, so there was not selection bias. And the primary outcome was the quality of TME specimen. And other than secondary outcomes were taken as circumferential and distal resection margin, number of nodes, morbidity, and bowel functions, which is very important with quality of life. And 160 patients were assigned to this study, and TME quality was found similar in both robotic and the laparoscopic group. But if we see the functioning of the post-operative outcome, functioning and quality of life of patient, sexual functions of the 12-month post-operatively was much better in the robot groups, because we have saved nerves much better in robotic surgeries. This is another small video when we go for pelvic splanchnic nerves. In first video, I've shown the superior hypogastric. Now we go for the pelvis. And if we see the pelvic nerves, we can see that when we go for the lateral dissection of the TME planes, we come across the pelvic splanchnic nerves. There are small branches that goes directly to rectum, and rest of the pelvic nerves has to be preserved. This we can see clearly, this rectal nerve, this pelvic nerves has been preserved, and TME planes are well maintained. This better visibility and dissections is provided much better in robot. So this is the right side, and here we can see this is the left side of the pelvic nerve, and we are going in exactly bloodless TME plane, preserving all the nerves all around. And another thing I would like to mention, when we are going deep into the pelvis, what problem we come across in laparoscopic surgery is lot of smoke and lot of scope changes. We have to come and clean again and again. But in robotic surgery, if we see this video, there is very less fumes and the smokes, and we are not using any smoke evacuation devices. And we can see that this smoke is not hampering our surgeries, because in robotics, we are using the lower cautery settings, which causes very less fumes, because we are directly engaging the fibers which we want to divide, and this help us keep our operating field very clean. So we can see these are the seminal vesicle, these are the pelvic nerves which has been preserved, and this function of the lower genitourinary functions are well preserved. So in this real-time studies, eligible patients were 18 to 80 years with the middle and the lower rectum. It is important middle and lower rectum because the nerves and the surgeries becomes difficult when we are goes in the narrow pelvis. So there were T1, T3 lesions, and with the N0 to N1, there was no distant metastasis. And 1,240 patients were enrolled in these studies of the lower and middle rectum, dividing both almost equally in both groups. And we can see that the patient in the robotic group had much better post-operative GI recovery and shorter post-operative hospital stay, fewer conversion to the open rate in comparison to lap surgeries, and definitely significantly less estimated blood loss, and intraoperative complications was also reduced in robotic surgery. Then I'll come for the urological and sexual function. These are much concerned in when we are surpass the quality of the surgery in point of oncological views. Then comes for the quality of life, and we can see in the prostate symptom scores was much better in robotic surgeries at 3 months after surgery in lower rectal cancer surgeries. And the international index of erectile function score was much better in robotic groups. This is the inferior hypogastric plexus, where I have left the videos before. This when we see the seminal vesicle, then we come across the nerves which are supplying to the lower genitourinary system. So these are some dissections in the deep pelvis, where it is difficult for the lab to see the vision clearly because of fume, because of blood, because of planes, and dissections becomes much difficult here, especially in the male pelvis, which is narrow pelvis. So here we can achieve much better nerve preservation in robotic surgery. We can see that the nerves which are supplying to the genitourinary systems and the seminal vesicle, prostatic part, these are the inferior hypogastric plexus and nerves which are well preserved. This is the bunch of plexus which is preserved, and the TMEs has been achieved very well. Both sides of seminal vesicle, we have gone much deeper to the seminal vesicle levels. In the deep pelvis, levator ani has been visualized, endopelvic fascia is visualized, and we have dissected a TME plane very well, preserving all the nerves. Then comes to the anastomosis part. Definitely, most of the time we are using the staplers, but sometimes we have to go for the manual anastomosis by the suturing in the 4 layers. And this dexterity of the instruments in articulated instrument of robotics, and stable vision, 3D visions, which helps us in holding the needles efficiently, which helps in maneuvering the movements, just like we are doing it in open surgeries with our own hands, which is much better. And we can do the 4-layer anastomosis very easily in robotic surgeries in comparison to lap surgery. So this is the 4-layer anastomosis, side to side rectum, where we could have applied stapler easily, but sometimes we feel because of economical constraints, the hand-sewn or manual anastomosis easier with robotics. Then in the right side colon surgery, similarly, robot-assisted colectomy in Japan, they have shown that there is the non-inferiority of the robotic surgeries in robot-assisted colectomy, and almost they are both robotic and laparoscopies are similar if we are considering the right-sided colon cancers. In particularly right-side colon cancers, I feel they both are good, and neither robotics nor laparoscopy is inferior in any respect. The advantage of right colectomy with robot versus laparoscopy is another study shows there was a number of harvested lymph nodes was significantly higher in robot assisted right colectomy, and there was a shorter hospital stay with robotic assisted right colectomies. Then I come to the lowermost part of the bodies for the robotic surgeries, which is very important. Where the robotics was started is the prostate surgeries. If we go for the comparison of robotic and laparoscopic prostate surgeries in LAP 01 trial, it shows that it is again a multicentric trial, includes the 782 patients, comparing the functional and oncological outcomes between the robot and lap after 3 months of follow-up. And the primary outcomes was the recovery at 3 months, especially the patient urinary continence and the erectile dysfunctioning. And second, definitely these both are very important for the prostate surgery point of view. So this in meta-analysis, it was concluded that early continence with robot-assisted radical prostatectomy at the 3 months, where the erectile function recovery was much improved with the robot assistant, and there was no significant perioperative morbidity or oncological outcomes in both groups. So for oncological point, robotic and laparoscopic prostates are same, but nerve preservation and erectile functionings are much better in robotic groups. This is the DVC ligation, which is the most difficult part, or which is in prostate surgeries, which are in deep pelvis. Again, vision is important, and it is a site where we can have a tremendous bleed here if we are not doing it properly. If we have any difficulty in this narrow pelvis, it can be very dangerous, and we can have a drastic hemorrhage here. So DVC ligation, because of dexterity, 360-degree movement of instrument, and better vision, we can do this ligation and dissections much easy, like any routine surgery. After that, the anastomosis in the deep pelvis is also important. That also I would like to demonstrate a little bit. Bilateral vas deferens has been divided after peritoneal plane has been opened, and bladder has been mobilized. Then we retract and develop the space of ridges anteriorly to the bladder. Here we are focused on preserving the nerves. This is the endopelvic fascia dissection, where the nerves goes laterally. We have to be very careful when we are dissecting the pelvic floor muscles, preserving the nerves. So this is the endopelvic fascia. Previously, here we can see the nerve fibers are being in the screen. They have been lateralized, preserving the pelvic functions, and endopelvic fascia is being explored. They are the pelvic floor muscles, and the nerves has been lateralized. Again, this is the DVC complex, which will be ligated. And after that, we can take a cut on the bladder neck, and we can transect the prostate divide of fat, and the bladder neck has been opened. Prostate has been lifted up. Everything is very clearly under vision, so that we can identify all the nerve fibers and all the dissections without any significant blood loss. So that's why it decreases our blood loss part. Both sides of pelvic prostatic pedicles has been clamped. First left, then it is right. Nerves in being lateralized, pelvic pedicles are divided. Now this is the urethral transection. Urethra has been divided. You can see the Foley is coming out, then urethra has been divided. Then we have to dissect the plane between rectum and the prostate gland. And after that, the most important part is the anastomosis. Again, this is an hand-sewn manual anastomosis where the urethra and the bladder neck has been anastomosed. And this 360-degree movement of instrument gives a lot of help. We can easily dissect, we can easily anastomose, and we can take the bites very easily in such a narrow, deep pelvis also. So this is the uretrovesical anastomosis. We use the barbed suture for the anastomosis so that the third instrument is not required to hold the suture and give a constant traction here. So this way, then in such a situations, I personally feel terrible if we are using the laparoscopy, because we may not get that level of movement in the laparoscopy in such a deep pelvis.
Yeah.
So with that, I would like to conclude my presentation, and I'll be very happy to take any questions from the floor. Thank you.
Thank you so much, Dr. Vikas Jain, for your insightful and interesting presentation. So I can summary. So adoption of robotic surgery improve oncologic outcome and precision compared to conventional laparoscopic and open technique in various cancer types. So maybe is from the audience or participants, is there any question to Dr. Vikas Jain? Because this is very interesting presentation about robotic surgery. So if there are no questions, so I would like to ask Dr. Vikas Jain. So in Indonesia, maybe the robotic surgery is still developing, but not as much as yours in India. So I want to ask, in your practice and experience, what is the best candidate of gastrointestinal cancer patient to perform a robotic surgery, not laparoscopic or conventional open surgery? So is there
See,
any
for all
indication?
purpose, it is just the anesthetic fitness. There is not the particular choice whether which patients can be go for laparoscopy or which patient can be go for robotics. Whichever patient, if they don't have any financial issues, we definitely prefer to go for the robotic surgery in all GI and genitourinary system surgeries. Especially, we enforce the robotic surgery, especially for the esophagus and prostate and hysterectomy, where the access for the direct open surgeries or laparoscopic surgeries becomes a little bit difficult for us. And overall recovery wise, if they can afford, definitely robotic surgeries in all patients is much beneficial than the open surgery.
Thank you so much for the answer, Doctor. So there is some question from the audience from Dr. Bambang Suprapto. So to Dr. Vikas, do you have any struggle docking to abdominal phase to thoracic phase for me? Thank you, Doctor.
Memang actually, it is not the docking struggle. It is just we need to change the position. Otherwise, the position, first I want to tell that we are not using the Da Vinci system. We are using the CMR system. And CMR system, the port positioning and everything is as same as we are doing in the laparoscopic surgery. So when we are changing from laparoscopic surgeon to robotic surgeon, we don't feel any difficulty in port positioning and docking systems. And it is a standard procedure of docking. We take around 15 to 20 minutes in docking process. Definitely, when we are changing for the esophageal surgery from thoracic phase to abdominal phase, we just need to change the position, and definitely the abdominal port will be totally different from the thoracic phase. There is no significant struggle.
Okay, Dr. Bambang, is that enough for the answer from Dr. Vikas Jain? So I think that is enough. Thank you so much, Dr. Vikas Jain, for your explanation and presentation. So we will proceed to next presentant.
Thank you.
So for the next presentation is from Professor Baiju Senadivan. He is a gastrointestinal surgeon from Sri Uttaradam Tirunal Platon Hospital, Trivandrum, India. That he will present about laparoscopy major hepatectomy. Time is yours, the professor. Thank you.
You, Dr. Kaur. giving this opportunity. Thank you, American College of Surgeons in the Indonesia chapter for giving me this opportunity, and thank you, Dr. Maria, for introducing me to this. So the topic assigned to me is lab major hepatectomies. I'll be going through the technical aspects of lab major hepatectomy rather than its theoretical aspects. Yeah. This is our own publication, which was published in 2014. A laparoscopic liver resection, bridge resections to living donor hepatectomy are we heading in the right direction. So we published 10 years back, and we could find that there have been minor hepatectomies happening in early 2000s. And by the end of 2010 and 15, there happened many major hepatectomies all over the world, and the world was moving towards laparoscopic living donor hepatectomies. So I'll be going through the technical aspects. So you will have to have a good preoperative workup before taking the patient to the theater. You should have a good triple phase CT, and you should sit in the console with the radiologist if possible to read what is happening in the films. And you need to do a CT volumetry, especially when you are dealing with a cirrhotic liver. And lesions in the relation to the portal and caval structures have to be delineated and to be named if it is possible. And you need to have a plan B, like open surgery, before embarking into laparoscopic surgery. Now coming to the theater setup, you must have a table with a good tilts, and you must have at least 35-degree up and down. You must have at least 25-degree right and left. And the anesthetist should be well informed regarding the control of the central venous pressures. And when you are dealing with vascular structures, the central venous pressures should be less than 5, and if it is minus, that is pretty well. And you should have a good laparoscopic vascular instruments in your armamentarium, and you should have a vascular staplers. And I'll come into the energy devices, and you should have a open mind in your heart that you should be ready to convert whenever you are landing up in trouble. These are the vascular clamps which we use in our armamentarium. The one first is the DeBakey clamp, which is especially designed for laparoscopic surgery. You can put a subcutaneous incision and put the clamp inside whenever there is an IVC bleed or something. And the second one is the bulldog, and you can see that it is a detachable bulldog, and it can disload the bulldog after application. And the third one is the chitwood DeBakey, which again, that is a curved DeBakey, which can be introduced, especially you can use it for Pringles maneuver like this. In hemostatic agents, you can have a harmonic or ligashore, different industry equipments are there. CUSA is pretty good if you are having it. I usually go with water jet and organ plasma coagulation. My main tools in my hands are harmonic scalpel and bipolar forceps. And the chance of embolism is there if you are using organ plasma coagulation. So you like to be releasing the carbon dioxide outside when you are using the these organ plasma coagulation. For parenchyma, I use water jet. This is the water jet machine which is available. And the second one is the CUSA. I rarely use CUSA for laparoscopic liver resections. And if you have a 3D simulation of the images by the CT, that is pretty well, that is good, and you can very refinedly go for the surgery. Intestine fluorescent green imaging is coming in a big way, And this is publication which was published in 2022 in Annals of Surgery. And you can see that from 2012 onwards, the use of indocyanine green has come to this level, and people are more or less using indocyanine green, especially in parts of Japan. So there are two ways of staining with the indocyanine green, that is positive staining and negative staining. So you need to have a algorithm for the indocyanine green staining. The positive staining, you inject 0.25 milligram per body weight directly into the tumor, and for negative staining, you inject 2.5 milligram per body. And the timing of staining, you can see that in HCC has to be injected 7 to 14 days before surgery, 0.5 milligram per kilogram. In impaired liver function, if the liver is normal, 0.5 milligram per kilogram body weight 3 to 7 days before surgery, or 2.5 milligram 1 day before surgery. This is the algorithm which is given by Taiga Wakabashi. Now, Penguin's maneuver, we can do many ways. This is the Foley's catheter, which is being used for Penguin's maneuver. I showed you the DeBakey, and this is the umbilical cord tapeworm, which is used for Penguin's maneuver. And I use rubber band technique for dynamic retraction of both the lobes of the liver, and it is coming in a big way, and people are more or less using the rubber band technique. And for parenchyma pursuing liver resection, which is popularized by Guido Toselli, is at ultrasound guided as well as ICG guided, but it's more or less possible with robotic surgery. I don't think it is possible with laparoscopic surgery. You can achieve R1 vascular resections with parenchyma pursuing surgery. Now coming to sectionectomies, we like to ligate the sectorial pedicles. Extrahepatic, and you can dissect. I usually go for the extrahepatic glycosyl approach for the right posterior sectionectomy, right anterior sectionectomy, right, left medial section, and left lateral sectionectomies. So there are planes which is determined by vascular structures. You can see the literature that intersegmental plane of liver is not always fixed for anatomical. This you can go through the literature which was published in 2010 in Annals of Surgery. Now coming to the variations that happen in portal vein, this is the most common type of portal vein bifurcation or trifurcation which is happening. This is 4A, this is 4B, and this is 3 and 2. So 2 and 3 is separate all the time, and there is a common branch for 4A and B. And this is the second most common type is 4B down from a single trunk, and 4A the same trunk. And this is the separated branch from the left right portal vein. So these are the variations which is available. We have to be familiar with the variations. Also, we have to find out any variations are there in the films. Now I go through a left hepatectomy with the caudal. This patient is actually a patient with the peripheral cholangiocarcinoma towards left. Since it is towards left, we have to take the caudal lobe also. You can see the port positions here. So this is the umbilicus, and you can see that this is Toloma port and this is another Toloma port. I am going through the epigastric port for the retraction and my right hand. And here you can see the extreme right hand port, only 4 ports being applied. Why Toloma ports? 2 Toloma ports is because probably sometimes because of rotation, the plane of resection will be angulated. So you can use either ports for depending on the angulation. Now I'm going through the hilar plate. That is gallbladder dissection. First, we have to do the hilar dissection. using a bipolar forces for hilar dissection and identify the artery and vein. And that is the artery. Initially, we thought it is the common hepatic artery, but finally we found it is not the common hepatic, it is the left hepatic artery. So we can see the segmental branches of the left hepatic artery there, 2, 3, and 4. And there is a branch downwards that is being taken care. And what you are seeing on the right side of the hepatic artery is the lymphatics. So go check the branches of the left hepatic artery, check for any anomalies, and then only you try to dissect or resect. Now we can see that after further dissection, found that the right hepatic artery is lying behind. That was going through a lower division of the bifurcation, that is the left, and that was having a lower division going to the right. That is the portal vein which is being exposed, and the lymphatics is taken care with the bipolar forces itself. Now a branch is taken, and the polycystectomy is performed after ligating the cystic artery and cystic duct. Now that is the right portal vein, and that is the left portal vein. And confirming that it is the left only, left arterial resection is happening after application of vascular vascular clips. Now that is the left portal vein. Now clips are applied to the left portal vein, and mind you, this is the portal vein is traveling to segment 2, 3, and 4, and segment 1 is paired. So which we will be taking it later. Now demarcation of the liver has parenchyma has happened. You mark the liver depending on discoloration. Now with the harmonic scalpel, up to 1 centimeter of the parenchyma, you can go with the harmonic scalpel, and deep to that you have to use any resources like fuse or water jets. So up to 1 centimeter with the bipolar harmonic itself, because there are not much of important structures there. Now I'm using water jet for parenchymal resection. So here you could see that there is not bile duct division has happened. That will be divided later. It's always better to do the bile duct division after a part of that is the bile duct which is being resected. So now with the water you have to delineate the structures, and that is the segment 4 vein, 4A and 4B is happening. That is the 4A vein going to the top, and further decision happening to find out the segment B vein, that is just below the segment A vein. And that is also taken care. Now further parenchymal resection is happening with the harmonic and bipolar forces and use of water jet like this. And once you reach the left hepatic vein, you delineate the left hepatic vein with the water jet and the available gadgets. Now you are exposing the left hepatic vein. Now the left hepatic vein is taken care of with vascular staplers. White, I usually use white. Now what is remaining for technical reasons, we are taking the caudate lobe separate, and we will expose the caudate lobe branch, that is the portal vein, caudate branch, segment 1 branch taken separately. And take the arterial division, and that is the direct branches from the IVC to the caudate lobe. Here, an unfortunate incident has happened while dissecting the caudate from the IVC, that one of the clips which was applied has fallen off while doing this section. That you can see that. So there will be direct jerking of blood from that area. Unless you are having good control of this one, probably you may have to pack and do open resection. Now you can see that I got a control of the vessel by the it's not a vascular forces, by the bowel forces. Still, I could control or give it to the assistant. I'm putting another port to suture the rent over the inferior vena cava. So 4-5 bites with 4-0 proline in this case. You can see that the control is good and the IVC is sutured. And the further dissection of the parenchyma is happening, and the parenchyma, the liver is resected without much hurdles. And you can see the left vein, segment 1 vein, you can see the right artery, you can see the parenchyma resection which attained hemostasis. You take out this specimen in a bag and take out through a small fan and steel incision. Now this is a video for right hepatectomy. I will not be showing the entire video. I can see that the right lobe is being mobilized. You can go through the mobilization of the peritoneum, just attaching the liver capsule, just anterior to the suprarenals. And there will be always a right inferior right hepatic vein, which has to be tackled before you mobilize further. That is the right inferior vein. So sometimes there will be 2 veins like that. So you like to have, before clamping the second vein, you like to be you like to have more control over the veins and the parenchyma. So unless you predetermine the ligation by CT scan, it is right inferior. Applying one more clip for safety. Now coming to the calyx, that is another vein which has been not been ligated here because of the indefinite anatomy. Now that is the lymphatics which are seen in the other case also been resected after applications clips. Now mobilization of the gallbladder to lower the hylar plate. Cholecystectomy without removing the gallbladder. Now further dissection of the cystic plate is happening. And you could see a extrahepatic branch which was going to the sectorial, that was a sectorial branch which I am dealing with later. And what after lower the hylar plate, you can see the portal vein there. You can see the right portal vein, which is going to the right. Now after like that is the right portal vein, applying a vascular sling to the right portal vein. Now the right vein is being clipped. that is the artery. Application of the clips on the specimen side. Now looking for the demarcation, because that is coming in the demarcation line, the gallbladder is being removed. And nowadays we use the rubber band technique for retraction. Here I am not using rubber band technique. Instead we are catching with one forceps. Now the parenchyma resection, as I told you in the other case, we are moving 1 centimeter deep with the harmonic alone, and then we'll be going with the either fuse or water jet. Initial parenchymal dissection is happening. In this case, actually, this is a case of again a peripheral cholangiocarcinoma. So that is towards the right, not coming close to the confluence. So here, what I'm doing is that after division of the parenchyma, I'll be incising the bile duct, because you need to have a better clearance. If you apply clip there, probably you will not be getting a good margin. So applying a incision, opening the bile duct, and then this is branches of the middle hepatic vein, which has blood during clipping, and I am controlling the middle hepatic vein with the stitches. So as far as possible, you have to keep the middle hepatic vein towards the patient, not to the specimen. Now further dissection of the parenchyma, taking the vascular structures and bile ducts. That is the vein in between. Now we can see that the bile duct was resected at the confluence to get a good margin, and I am suturing with the 40 Vicryl. So that you will get a space there to give more margin to the right duct. Your suture should be so precise that it's not robo, precise that there should not be any constriction of the confluence. Probably robo can give a good suturing skills here than hand sutures in laparoscopy surgery. That is the final bite from the bile duct. And the further this session is happening as happened for the previous case. So I'm not going to the. This is another for the sake of time. I'm not going to second segmentectomies. So this is our own article for, published recently. Post-hepatitis venous thromboembolism systemic review with meta-analysis scoring the role of pharmacology with thromboprophylaxis. The current study supports the use of VTP in the post-hepatic patients. This is a very strong recommendation from the meta-analysis. To conclude, laparoscopy major hepatectomy is a major complex procedures demanding very high skill setup you should have a good team of surgeons, paramedics, and anesthetists and intensivists, and you should have a low threshold of conversion while doing these surgeries. Thank you for your patience.
Thank you, Professor Baiju, for your nice and insightful presentation. So I can summary. So laparoscopic major hepatectomy offers several advantages over traditional open surgery, including reduced blood loss, smaller incision, faster recovery, and shorter hospital stays. But also it requires advanced technical skill, but has been shown to have comparable oncologic outcome with improved post-operative recovery compared to open surgery. So
Absolutely.
is there any question from the participants to Professor Baiju, maybe? So if there is no question, maybe I will ask some question to Professor Baiju. So as we know that if we do the hepatectomy procedure, the most common complication that can occur on the operation is the bleeding. So is there how you can overcome this in your experience, and maybe if is there any preoperative preoperative things that you do or postoperative thing that or can minimize the bleeding intraoperatively? Thank you, Professor Baiju.
Yeah, as I told in the first slide itself that you have to have a good CT film, and you have to sit in the console with radiologist regarding the vascular structures and any anomalies, even biliary anomalies and vascular anomalies, is common in the case of liver resections. And if any anomalies, and if you're going for a liver resection for tumors like colorectal metastasis, you have to identify each and every vessel around and name it. Temporally, the name is A, B, C, 4, like that. And you identify the veins operatively. And you inform the intensivist, the anesthetist that let keep the CVP pressure always low. If they are keeping the CVP pressure above 5, most probably when you are having a bleeding, you will not be able to catch the bleeding, or you will not be able to see the bleeding point. So if you're keeping the CVP less than 2 or 3, even if the IVC bleeds, we can see the blood flowing inside the IVC but not coming out. So the role of the anesthetist is very important, and you should have a good coordination with the anesthetist while the patient is having bleeding, and he should not rush in lot of fluids while having the bleeding, because that will cause more bleeding and you will not be able to control the bleeding. And as far as possible, keep a gauze piece inside the abdominal cavity itself, even if it is not needed, because by the time you are bringing the gauze piece from outside, probably there will be much of bleeding. So whenever there is a bleeding, you can take the gauze piece then and there. And second thing, there always control the bleeding with your non-dominant hand. Here in this case of IVC bleed, I am controlling the bleeding with my non-dominant hand. Why? Because that will give you the reflex of non-dominant hand, and the right hand will give you the more maneuverability, and you can give that non-dominant hand to another person, put another trocar so that you can use that trocar for your non-dominant. So keep a cool while doing the resection. Whenever there is a bleeding, keep a cool, and we can control the bleeding most of the time. And if it is not possible to control the bleeding, always have an open mind to open the case and convert into open surgery.
Thank you, Professor Bayu, for your explanation. So this is from the question from the chat box. So there is one question from Dr. Anu Nugroho. So maybe where can we buy the instrument for the laparoscopic hepatectomy? Maybe what is the product? Maybe as a general, is that the same one as the instrument for the laparoscopic procedure? Thank you, Professor Baiju.
Even the instruments which are shown in the figures are not available widely in India too. Some of the instruments we have procured from outside, especially Germany. Yeah, in initial cases, I used to use this the open bulldog taken through the abdominal cavity through the 10 mm or 11 mm port without taking out the port from the incision and put it inside. Keep it there. Whenever it is needed, you can use it. But you should have a very good control of the instruments, especially when you're using open bulldogs. But lab bulldogs, you don't have to have such of good skills to apply. But open bulldogs, because that bulldogs will slip on in your hands. So these instruments are available with the German companies. Probably we will we have the habit of duplicating things in our industry. So we can have the ditto from our local vendors also.
Okay. Thank you so much, Professor, for your explanation. So is for Dr. Anung, is that enough? So thank you also for Dr. Vikas Jane for your sharing. So laparotomy bulldog easily available in India also. If Dr. Anung may be interested, you can ask instrument from the India. So maybe thank you so much, Professor Baiju, for your presentation and for your sharing about the laparoscopic hepatectomy. So we will continue to next presentation from Professor Iswanto Suchandi. So he's a professor of surgery, hepatopancreaticobiliary surgeon from University of Florida, Advent Health Tampa, USA. That he will present treatment of the metastatic colorectal cancer to the liver. So time is your professor. Thank you.
Thank you. Thank you. Selamat pagi. Thank you very much for the invitation by the International College of Surgeons Indonesian section. I will talk and share with you, I think, a very important concept of the surgical treatment for metastatic colon cancer to the liver, which is also common in Indonesia, same in anywhere else in the world. I hope you can see my slides. I'm going to run the slides now. So surgical treatment of metastatic colon cancer to the liver. Just the background, it is the third most common cancer in the US. A lot of cases of colon cancer, more than 100,000 per year. Half of them are rectal cancer. 50% of colorectal cancer will spread to the liver, either synchronous or metachronous. Liver is the only site of metastasis in about 40% of patients. And the primary curative option is to resect the patient and try to achieve R0 margin. This is a very important statistic that I want to emphasize and re-emphasize to everyone. Unresectable patients have a poor 5-year overall survival, which is only maximum of 10%, 0 to 10%. Resectable patients have significantly better 5-year overall survival because it goes up to about 60%. So from 0% to 60% with the tumor being resectable. There's enough paper that was published about the mechanism of colorectal metastasis, but the bottom line is the tumor cells proliferates in the primary site. It breached the basement membrane. It passed through the extracellular matrix. It goes into the portal venous circulation. The tumor cells got transported into the liver, attached in the basement membrane of the liver, and it formed the micrometastasis or macrometastasis. Micrometastasis is the one that you cannot see. Macrometastasis is the one that you can see on the CAT scan and also during the operation. This is a historical perspective, which I think is important. This is the first paper from Mayo Clinic from 1983. You can see here on the picture on the left side, the tumor that has a solitary lesion, a single tumor, and the patient that have a multiple unilateral tumor, and the patient that have a widespread tumor. And you can see here, without treatment, the overall survival is quite poor. In 5 years, almost nobody survived. Therefore, the effort to try to resect them is very important because that will improve the survival. This is the comparison also from the Mayo Clinic. You can see here on the graph, patients who are resected with no residual disease, the 5-year survival goes up about 35%. Patients who are not resected, the survival is very low. You can see here on the second line. And the patient who have multiple tumors not resected, they barely reach 3-year overall survival. So the bottom line is try to resect the patient as long as they can be resected. This is another long-term paper that was published by René Adam. René Adam is the next president of IHPBA. You can see here again, similar graph. However, this is a 10-year graph. In the patient who are resected at 10 years, 25% of patients will be alive. 1 out of 4 patients still will be alive at 10 years with good resection, while the patients who are non-resected, they barely reach 5 years. Even 10 years, forget about being alive in 10 years. The take-home message is resectable patients should undergo liver resection in order to keep the patient survive. Comparison between surgery and chemotherapy versus chemotherapy alone. This is a lot of cases, even in America, that we can see in the community. A lot of patients, they only get chemotherapy because the medical oncologist is hesitant to refer the patient for surgery because everybody thought this is stage 4, as futile for surgery. You can see here the chemotherapy outcome at 60 months, 5 years, is very poor compared to the patient that have surgery and chemotherapy. So point number 2 that I want to discuss with you, a very important concept as well, that the treatment has changed dramatically in the last 30 years. Surgical resection for hepatic and extrahepatic disease is now more aggressive. Systemic chemotherapy is improved, both effectiveness and the ability for the patient to tolerate the side effect, which is become less and less side effect of the chemotherapy. The safety and the outcome of liver resection also improved. In the 1970 or 1980, open hemihepatectomy, right hepatectomy or liver hepatectomy, will lead to about 20% mortality. Today, it's only less than 0.3%. So the use of liver resection becoming more common because it is safe, the outcome is good, nobody needs to be scared about open hemihepatectomy, and this open up more opportunity for the patient to be cured with even major resection. Some history of surgery, which I think is important to know the history. In 1976, the surgical treatment of hepatic metastasis was explored from colorectal cancer disease. And you can see here in 1976, the recommendation to do surgery is only for minor liver resection in the patient with solitary single lesion. So the surgeon agreed that aggressive but only minor resection of a solitary liver metastasis can be justified. You can see here, this is the standard of care in 1976. 4 years later, in 1980, the standard of care again changed. At that time, 20 to 30% of patients were able to benefit from major hepatic resection of the large metastasis. 20 to 30% of patients were able to be kept alive, survive, even with major hepatic resection. Therefore, the standard of care at that time changed from minor liver resection to a major liver resection within only 4 years. Fast forward, 2000. This is 20 years after the last paper. At that time, the surgeon became better at doing liver resection, safer. And at that time, we knew that the resection of bilobar, so this is right and left lobe of the lesion of the liver, can lead to a similar outcome compared to the unilobar, right only or left only. The 5-year survival at that time increased to 37%. Remember, at the first paper, the 5-year survival is only 20%. So the survival increased with time because of the better surgical technique, safer surgery. At that time, it was also known that death rate is increased if the surgeon performed extended lobar resection. It means extended right or left hemihepatectomy, or it's combined with colorectal resection, which is now is no longer true. At that time, again, the guideline was revised to include multiple bilobar liver metastasis that has improved surgical outcome with resection. In 2005, 5 years from the last, what happened if the patient have a tumor recurrence in the liver? The patient have a resection before. Should the patient have resection again? The answer is yes. Repeat liver resection improve overall survival and has low operative risk. As long as the operation can be done safely, the patient have enough future of a remnant, and the patient has ability to tolerate the operation safely. This is another paper that was published 2016. What happened if the patient have liver metastasis and lung metastasis? We are now discussing an extrahepatic disease. Should the patient be let alone and not given any chance for surgery because they have a 1 or 2 lung metastasis? The answer is, if the lung metastasis can be controlled with radiation or local resection, the patient should undergo liver resection. This is a very clear graph that compare resectable patient, resection versus non-resection for synchronous metastasis. The outcome, survival for resection, is much better than the patient who have no resection for synchronous metastasis. Synchronous means the liver tumor was diagnosed within 6 months of the lung tumor. This is a patient with metachronous resection. It means the diagnosis was 6 months or more apart. Again, the resection also bring better survival for liver and lung compared to patients who are not resected. Important concept. This is a similar paper from Memorial Sloan Kettering. Also emphasize the same principle, but both hepatic and pulmonary metastasis, when it's resected, it will able to bring prolonged survival in selected patients. You can see here the numbers. Up to 10 years, there are good amount of patients who are still able to survive. Almost 20% of patients are still alive at 10 years, even with lung and liver metastasis, as long as they can be resected to clean margins for both. Now, the question is, where is the limit for liver resection? Seems like we are doing more and more. The answer is yes, we are doing more and more. Where is the limit? The limit is general health of the patient and performance status of the patient. Underlying hepatic function. They cannot have too much fatty liver disease. They cannot have too much cirrhosis. They cannot have too much chemotherapy or NASH, non-alcoholic steatohepatitis. 3 is a background liver. Had the patient had prior TACE, hemoembolization, radioembolization, HIA pump, hepatic artery pump, or prior major liver resection, we can limit the next operation. The question is, how much liver volume is enough to avoid postoperative liver insufficiency, or also named postoperative liver failure? This is the important factors. The surgeon needs to determine the anatomy of the patient, to need to study the volume of the future of a remnant and the volume to be resected from a CAT scan or MRI. And also, it is even better if there's a functional status evaluation of the liver remnant. It can be done with ICG. In the East, people use ICG. In the West, people use a TC99 scintigraphy. And basically, the bottom line is the test works the same way. The materials is taken by hepatocytes secreted in the biliary system, and from there you can do a scan to see how much or how rapid the clearance of the liver to those two materials to determine the hepatic function. This is a three-dimensional reconstruction. This is AI. Somebody talked about AI before. This is something that we routinely do in our program in Tampa before any hepatic resection, especially the major ones. So you can reconstruct the CT scan to exactly see where the tumor is in green on the right lower quadrant image, and you can see how much liver to be resected, how much liver to be preserved, and you can see the branching pattern of hepatic vein, portal vein, and everything else. This will make the operation safer, easier, and more predictable. This is important numbers that I would like everyone to know. In liver surgery, normal liver, 20% is enough. Patients who have extensive chemotherapy, meaning more than 6 months of chemotherapy, the patient must have 30% of liver remaining. And the patient who have cirrhosis, they should have 40% of liver remaining in order to avoid liver failure. What are the management options for the patient who came with insufficient liver remnant? They have a future liver remnant that is too small. The answer is we need to try to grow, to try to nurture the future liver remnant to become a larger size. How? One is through a portal vein embolization. The second is through simultaneous portal vein and hepatic vein embolization. It is called double embolization. And there is one more way, which is what we call ALPS procedure, where you split the liver and ligate the portal vein on the site to be resected, which will give the ability for the future remnant to hypertrophy. And later on, you come back and do a second stage completion hepatectomy. This is a picture, the same picture of what I mentioned, the tumors on the right side, and the patient needs to be resected on the right side. You can close the portal vein on the right side. It will induce hypertrophy on the left side. And you can even do a first stage operation where the left side is cleaned up by a local resection, and this will allow you to grow the left side of the liver by splitting the liver here and ligating the portal vein, which I will have a video at the end of this talk, or what we call the robotic ALPS procedure. This is a portal vein embolization. It's done by the radiologists. They close the portal vein on the tumor side, and it will grow the liver. If the liver grow more than 2% per week, it's called KGR, kinetic growth rate. If the liver, future remnant grow more than 2% a week, no patient will have liver failure postoperatively. If the liver grow less than 2%, you have to be careful because there is a chance about 20 to 30% of liver failure postoperatively with major extended resection. This is a relatively new concept that I want everybody to know. This is called double embolization. We actually do it here as well. I operated the patient yesterday after a double embolization. So in this procedure, the tumor is on the right side of the liver. The radiologists close the portal vein, right anterior and right posterior right side, basically deportalize right lobe, and also in addition to that, also come and close the right hepatic vein. In the picture on the right side, the patient have right and middle hepatic vein, both embolized, will even give a faster or more extensive growth of the left side of the liver, which will be prepared for a second stage hepatectomy. This is a graph that showed that with the double embolization, hepatic vein and portal vein, the growth is much faster with PVE alone, portal vein alone. This is an ALPS procedure that I will show a picture, a video later. This is the patient that have a stage 1 procedure of ligating the portal on the right, split the liver, clean up the left of the liver, wait for about 1 week, but sometimes wait for 3 weeks. The deportalized liver will shrink, the hypertrophy of the FLR will occur. You wait for about 30% of the FLR, and you go for extended resection as a second stage. Now, the third topic that I want to discuss is the need or the importance of minimally invasive liver resection. You can see the open liver resection is quite morbid operation, major resection. Sometimes you have to do it, but if they can be done minimally invasive, I think it's better. Why? Because there's many publications compared minimally invasive versus open, less blood loss, blood transfusion. The patients start drinking liquid the same day. less pain, shorter length of stay, less wound complication, better cosmesis, and so on. This is a similar survival in 5 years between open and laparoscopic, no difference. There's a lot of paper compare open and laparoscopic. The problem is there is no randomized trial at that time. So what happened? In 2005, the first randomized trial was planned. The protocol was published in the Clinical Trials of Gov. 3 years later, the outcome is published in the Annals of Surgery. This is the first randomized trial of minimally invasive versus open liver resection from Oslo University Hospital. Picture on the left side is Asmund. Picture on the right side is Ed Ben Bure, his boss. So the first randomized trial resulted that the minimally invasive liver resection has lower 30-day complication rate, shorter lengths of stay, and less pain medication requirements. Not long from the first trial, it is quickly followed a year later by the second randomized trial from Spain. Ricardo Campos is a friend of ours. The second trial shows, again, similar outcome pretty much, that the laparoscopic resection lead to lower morbidity and shorter hours of stay compared to open whenever it's feasible. Now, future direction. What is the future direction of liver surgery? Robotic surgery is one of them. Laparoscopically also improve, but the robotic surgery is going a bit faster. This is, I think, the future of surgery. Ability to do a vascular surgery with minimally invasive approach. So when you have to do a portal vein resection, end-to-end anastomosis, I think the technology enabled you to do this operation without much difficulty. And this can be done safely with good outcome. Portal vein anastomosis. This is a picture. This is a video that I want to show you. This is a robotic modified ALPS procedure for a patient with colorectal metastasis. This is a young patient, 40-year-old, with a colorectal metastasis, including the right side of the liver, but also he had the left adrenal metastasis. And this is the only site of metastasis outside the primary lesion. So the patient is scheduled for 2-stage ALPS procedure in the operating room, which includes several components of this operation. This is the CAT scan of the patient that shows a large tumor involving segment 4. It means the patient will need an extended right hepatectomy. The FLR is only 25%. This is the left adrenal metastasis. So you see here, this is a young patient who have extrahepatic disease and intrahepatic disease. This is a port placement. Stage 1 procedure will be ALPS, left adrenalectomy with a low anterior resection with temporary ileostomy for the primary rectal, upper rectal segment cancer. So I performed this operation, first and second stage both. This is first part of the operation, which is the left adrenalectomy. The pancreas was elevated cephalad, and you can see here behind the pancreas, immediately you will see the left adrenal gland. The left of the left side of the colon had been mobilized to the medial side, and this gives you exposure. This is the left adrenal vein. It was skeletonized, clip divided. This video is probably 1.5 years ago. And the adrenal is done. The next step is to do the first stage out procedure. This is the ultrasound examination to mark the transection line of the ALPS. Lymphadenectomy, a bit of lymph node sampling was done. This is the section of the right portal vein and the hepatic artery for the ligation of the portal vein. So you can see here, the right hepatic artery is being clipped, gallbladder is removed, the portal vein is skeletonized for later ligation. There's always a corded branch. This is a proline suture is utilized to ligate the portal vein on the right side. Now I'm utilizing harmonic and a Maryland forceps to split the liver along the segment 4. And this is the first stage out procedure. You can see here, very meticulous without Pringle, even though we have a Pringle tape on. We clip, divide in the middle. We split the liver all the way to the cava and stop approximately 1 centimeter from the hepatic veins. Small bleeding here, easily controlled with suturing, 4 prolines. I intentionally hang the liver up to the left side in order to separate the liver from the right and left lobe. This is the low anterior section. Again, it's done in the same sitting. This is a multi-port robotic approach. We flip the robot to the lower abdomen. ICG was injected. The upper rectum was stapled, and the rectosigmoid tumor is going to be removed. The patient will have anastomosis here with the temporary deferring loop ileostomy. Approximately 3 weeks later, the patient is undergoing a step 2 ALPS procedure. This is again the volumetric. So this is a repeat CT scan. The FLR grew from 25% to 35% with ligation of portal vein on the right side and splitting the liver. So this is exactly what we would like to see. Now we are going the second time again with minimal invasive. I have marked the hepatic artery at the first operation with the blue prolin suture so I can find it the second time. Again, I ligate it now. I ligate the hepatic artery on the right side, which completely revascularizes the right of the liver, which is going to be removed. Now we use ultrasound again to check the margin of the liver for the liver resection. This is opening the groove, which was split from the first operation 3 weeks ago. Again, we are going to do now extended radiopatectomy. This is a V8, which is transected. This is a branch of the middle hepatic vein. This is the caudate process. This is a paracaval portion of the caudate lobe being removed. Inferior vena cava is behind. Now we are going down to the area behind the portal vein. I staple the right bile duct, which basically disconnected the right of the liver from the portal area. We now move cephalad with a lot of suture clip. The vena cava is behind. I try to lift up the paracaval portion cephalad, and I try to disconnect the right of the liver from the remaining remnant. This is the right hepatic vein, was stapled. The second staple went for Makuchi ligament. So you see here, extended right hepatectomy is finished. This is the future remnant, lights up very well with ICG. This is a 2-stage operation. The first stage was 3.5 hours, second stage 6.5 hours. Operation went very well. Patient is now 1.5 years. No tumors. He's almost 42 years old now. He's leaving off with the left lateral sector of the liver with some segment 4 remaining, and the patient is tumor-free, doing very well. And he's very thankful because otherwise he almost cannot find surgeons to do this operation, but we are able to do this operation and give him oncological survival benefits. The adrenal gland came back as metastatic adenocarcinoma with the complete necrosis of adrenal gland, and the right hepatic tumor is 13 centimeter. Colon cancer to the liver is a huge tumor able to be removed minimally invasively with ALPS procedure. This is a recent publication from our center, 530 minimal invasive robotic hepatectomy. I encourage you to read. You can probably learn a few things from this. The conclusion, the surgical treatment of liver metastasis has evolved. The key is aggressive surgical treatment. As long as it can be done safely, the surgeon can do it well, the patient can survive, that will be the best for the patient. Minimal invasive technique, if feasible, should be the preferred approach. Surgeon holds a very important role in the management of disease, and this cannot be driven by medical oncologists. The surgeon have to hold the steer in order to get the patient to the best outcome possible. Thank you.
Thank you, Professor Suchandi, for your insightful presentation about metastatic colorectal cancer to the liver. So I can summarize. So liver is one of the most common location for metastatic colorectal cancer. Liver resection for resectable liver metastasis drastically increase survivability of the patient. It has relatively low operative risk as long as operation can be done safely and patient can tolerate the surgery. Maybe is there any question to Professor Suchandi about the presentation, maybe from the audience or from the participants? So not yet. So I will ask the question to Professor Suchandi. So there are 2 questions. So for the first question, usually for the metastatic colorectal cancer of the liver, beside liver resection in your center, what is the choice of the therapy that usually done to the patient before or after the resection of the metastatic liver? And the second question is, one of the option of liver section for metastatic case is to stage hepatectomy. So in your experience, when you usually do the second operation, and before we do the second operation, so how we can increase the survivability of the liver remnant so it can be safely performed and not resulted in insufficient liver remnant. Thank you, Professor.
Thank you. So this is, I think, is a very important concept that everybody should know, because in Indonesia also there's a lot of patients with hepatic metastasis, and many of those patients come with a very, very large hepatic metastasis, multiple lesions. So the treatment approach in our center and also in America in general, the patient start with a systemic neoadjuvant chemotherapy for about 3 months. It is important to try not to go beyond 3 months, especially if the patient is going to have a major lymphatic resection, because going above 3 months can compromise the recovery of the liver. So after 3 months, the patient need to have a repeat CAT scan to see the surgical candidacy. If the patient requires a 2-stage hepatectomy, at least one lobe of the liver needs to be resected with the goal of tumor-free in one lobe at that time. And then the patient can undergo more chemotherapy with a plan of second stage later on. Usually the distance, the interval between the first and second stage, it can be as long as 2 to 3 months if the patient is going back on systemic chemotherapy again. Now, if the patient is undergoing a more instant procedure, such as ALPS procedure, we usually wait. The original ALPS procedure is described that you have to wait for about a week, but in reality, we sometimes wait for 2-3 weeks to make sure the FLR is more than 35%. If you choose to do a PVE, portal vein embolization, you have to wait for about 6 weeks. So it is a slower process. It takes more process. Even with a double embolization, it is still about 6 weeks time. So it depends on the choice of procedure. Now, in our center, the choice of procedures is PVE with HVE, hepatic embolization. If they fail to achieve hypertrophy, the next steps will be ALPS procedure. It is important to know that not every patient will have growth of the liver, even after PVE. So this is something that needs to be looked at case by case. And if the patient have a chance of ALPS procedure, they should go for ALPS procedure. So it is important for the surgeons to be able to do the operation well, because sometimes one surgeon say it is unresectable, other surgeons say it's resectable. And this is basically something that is very important for the patient, because if they can be resected, the survival double or 3 times longer than the patient who are not resected. It is important to avoid liver failure also postoperatively, because liver failure is deadly. So it is important to study the case again, do a volume calculation after the second stage in order to do a safe hepatectomy to reduce postoperative liver failure.
Okay, thank you, Professor, for your explanation and sharing. So if there is no question from the audience, maybe I will proceed to the next presentation. Thank you so much, Professor Suchandi, for your insightful presentation. So we move to the presentation from Dr. Aaron Tan Yew Chin. He is a neurosurgeon from Sunway Medical Center, Penang, Malaysia. Time is yours, doctor. Thank you.
Share the screen. Okay, can you all see the screen? I think I need to.
Yeah, doctor. I can see your screen and also I can hear your voice clearly.
Okay.
Good afternoon, everyone. I'm Aaron Tan Yu Chin from Bagan Specialist Center, Penang, which is the northern aspect of Malaysia. It is honored for me to share with everyone regarding my topic for today. And first of all, I would like to thank you, everyone, the ICS, as well as Udayana University for inviting me to share with everyone regarding my topic for the day, titled Bipolar Spine Surgeries, New Horizons for Neurosurgeons. So without much ado, I think that I will start our first slide. So I will briefly talk about some history about minimally invasive spine surgery. Since 1960, when Dr. Yasagir introduced microscope to spine surgery, precision has been the hallmark and privilege of neurosurgeons. And in 1970s, Dr. Cambins introduced monopodal spine surgery and later on evolved over 4 generations from transforaminal approach to interlaminar approach, multiple versatile approach. But however, monopodal spine surgery is associated with long learning curve for some spine surgeons due to its limited vision as well as instrumental maneuverability. In 1996 and 2002, the first bipolar spine surgery was performed and published by Dr. D. Antonio, who is an Argentinian spine surgeon, as well as Dr. Abdul Ghaffar, who is a Bahrainian spine surgeon, which laid the first groundwork for bipolar spine surgery. Later in 2010s, the bipolar spine surgery was further developed and popularized by a group of Korean bipolar spine surgeons pioneers, whose names are Dr. Song Sang-kyu, Dr. Jin Hwa Dr. Sang Ho Lee, Dr. Hyo Dong Hwa, and so on. And in 2020s, we are observing the wave of China UBE. We are seeing a lot of local and international training camps by 2 pioneers of bipolar spine surgeons by the name of Dr. Yang Hejun as well as Dr. Zhang Wei, which solidified the Chinese role in global disseminations of bipolar spine surgical techniques. The bipolar spine surgery continued to extend its legacy, merging the microscopic precision as well as endoscopic minimalizations, which provides an unmatched accuracy as well as utmost clinical effectiveness. The hallmark of bipolar spine surgery is that it is simple, minimal, as well as flexible. Common indications for bipolar spine surgery include degenerative spine disease, tumor, infection, as well as trauma. Common procedures by bipolar spine surgery include discectomy, decompressions for stenosis, interlaminar approach, foraminal, extraforaminal approach from cervical, thoracic to lumbar region, fusion surgery, removal of certain lesions such as juxtafacet cysts, and some experienced bipolar spine surgery has actually attempted the techniques on spine tumor, which is not yet a regular and standard practice yet at the moment. There are some minor differences between monopodal and bipolar spine surgery. However, essentially, both of them deliver the similar outcome in terms of minimal invasiveness as well as clinical effectiveness. So the strength of bipolar spine surgery is particularly prominent in complex degenerative spine disease. For example, a calcified disc, for example, in this case, and it is good as it delivers a quick and fast recovery through small incisions, and the steps are pretty similar. And I would standardize and summarize that the procedures are all performed in 4 simple sequences, namely incisions, laminotomy, flavectomy, as well as discectomy, if it is required. So in another case of a calcified disc, which I will showcase the operative video, in this case, there was it looks like a straightforward posterolateral disc herniation, and there's no CT scan performed. However, intraoperatively, we found a calcified disc. However, similarly, no matter what kind of pathology, these techniques still maintain its hallmark, which gave a quick recovery after the treatment through two small incisions, and then the sequences remain the same. In this case, I will showcase the steps of how we perform the surgical solution for these patients. As for the incisions, we place the two incisions 2 to 3 centimeters apart, and the center will focus on the disc. So firstly, we perform the bone work. So for all the video in this, in my cases, I choose all right side pathology so that my audience will get confused with the orientations. So for a right side approach, over the right, it's the cranial, the left is the caudal, and then the inferior here is the lateral, and this is the medial. So for the bone work, we do a cranial laminotomy over here until the natural detachment of the flavum. With using this technique, we can work under a bloodless environment. And then this is the caudal laminotomy. We can see the fat of the nerve roots. So over here, we are drilling the medial aspect of the superior articular process. After the laminotomy, we will expose the flavum. The flavum is typically encouraged to be split in the middle because over here we get the most potential space between the flavum and the dura. So we use a Carrison to split the flavum over the midline and then open it like how we open a book. So with this, we will expose the dura. So we use a dissector or even a RF device to split it and dissect it carefully from the dura. Over here, we can estimate that the disc level will probably be here because we can see that the dura thicker sac is most compressed over this area. The removal of the flavum is done under direct supervision. Just in case that there is any dura tear, we will stop and we will continue with a dissection. After removal of the flavum, it will expose the nerve roots, and then we will use our K-wire to retract the nerve roots and perform intradiscal decompression in a safe manner. After the discectomy, I try to mobilize the nerve root, however, and encounter some resistance over here. So carefully, we dissect it, and we found that that is a hard dysosteophyte complex, which could be difficult to remove using a pituitary ronger. So over here, even in a deep angle in epidural region, which could be difficult to handle in an open surgery, but using this technique, we can safely using our drill to remove the calcified portion of the disc or osteophyte. After removal of offending pathology, we can see that now the nerve is become mobile, and then it also become more reddish because of a reperfusion of the nerve. This is the second case. I will showcase a video. It is a migrated disc. Sometimes it could be also be challenging even in open surgery or using a monoportal spine surgery where the approach could be slightly different from the standard. But however, using a biportal surgery, the sequence remains the same. We still perform a laminotomy and phlebectomy. After removing these two anatomical structures, we will expose the thicker sac. Then from here, we will use a retractor to push the nerve root, the shoulder of the nerve root medially With that, we can show our D-space. So this is how we use our quarterback K portals to retract the nerve roots in the safe manners. This is an RF device we use to perform homeostasis, and also we use that to shrink our disc. After the D-space exposure, we can continue to fish as well as extract the extruded portions of the migrated disc out in a safely manner. After removal of the offending disc, now we use a nerve hook to confirm that there is no other pathological agent which is compressing on the nerve, and then safely we can remove our K-wire. This is the third case I would like to share with everyone. In this case, there is a stenosis. The stenosis occurs centrally as well as a bilateral lateral recess. And in this case, because the right side lateral stenosis is more severe, so my approach is coming in from the right side as well. So this is the video of how we approach these patients. We come from the right side, and after removal of the bone exposing the flavum, we split the flavum through the midline. So we remove the flavum one side, then over the other. So you can see here the flavectomy was performed under direct supervisions to prevent, just in case that there is any meningeal vertebral ligament that attach between the flavum and the dura, causing dura tear. So it's a very safe technique that is performed under direct supervisions all the time. So this technique also provides adequate decompressions. For example, even though it's a minimal approach, we are able to see even the contralateral disc. At the moment, we are retracting the contralateral nerve root medially, and this is the contralateral disc, and we are using a RF device to perform annuloplasty. We're using RF energy to shrink the disc as well as to promote fibrosis. Hopefully, this will reduce a future disc prolapse recurrence. And over here, we can also see the contralateral pedicle, because an effective decompressions by open surgery is to be able to decompress the nerve from pedicle to pedicle. And yet nowadays we can achieve that using a minimal invasive techniques. So over here, I'm retracting the ipsilateral nerve root medially to expose the ipsilateral disc. So this is the ipsilateral disc. And again, the same thing, we're using the similar RF devices to shrink the disc, and at the same time to promote some fibrosis. Also, we are able to decompress the ipsilateral side and expose the ipsilateral pedicle. For grade 2 spondylolisthesis and a dynamic X-ray which shows instability, this is the extensions and flexions X-ray which shows instability in this patient. So these patients not just require decompression, also it needs fusion with instrumentation. So we can also achieve that using a scope. So this is how we do it intraoperatively. We identify the ipsilateral right side facets, and we perform a facetectomy using an osteotome. Using this technique, we can preserve the bone graft and use it for fusion later on. So the facetectomy was performed until the foraminal level. You can see that there's a natural detachment of the flavum over here. By taking out the IAP, we'll expose the SAP caudally. And the same thing, we use the osteotome to remove the SAP. After the SAP is removed, we can see the pedicle roof as well as the pedicle medial edge. We will remove the flavum. After remove the flavum, you will expose the disc. This is what we call as a safe Cummings triangle. And similarly, using the RF devices, we can meticulously dissect the neurostructures away from the disc. Then using an Indian knife to perform annulotomy at the medial pedicle line, further intradiscal decompression using a disc ronger, then disc distraction using a shaver. The beauty of endoscopic fusion is the ability to prepare the end plate thoroughly and completely, which will be translated into better fusion later on. After the complete end plate preparations, I continue to perform a decompressions over the contralateral side. One of the common complications of fusion surgery is that it leads to a worsening of contralateral lateral recess stenosis after the insertion of cage. So it's particularly important for us to ensure that the direct decompressions of the surgery is adequate prior to insertion of the cage. After adequate and satisfied decompressions of bilateral lateral recess, we come back to the lateral recess, insert the bone graft, and eventually our PICC cage. Post-operatively, we see successful corrections of a spondylolisthesis and in situ insertions of an implant, small incisions which will be translated into early mobilizations of the patients. So this is the fifth case, which is a case of a cervical disc prolapse. And you can see that over here, there is a severe C5-6 posterolateral prolapse just medial to the C6 pedicle. So this case can be approached through the front using endoscopic technique as well as from the back. But if I come from the front, I might need to use an implant, and these patients refuse the use of implant. So alternatively, I advocate endoscopic posterior discectomy for this patient. So first, we identify the C5 and C6 V point. This is the lateral mass. So we start performing the bone work. The bone work was performed until we see the margin of the flavum. And from here, we can already see this material just medial to the C6 pedicle. After the laminotomy, we perform flavectomy. So the flavectomy can be safely performed after we detach the flavum using a carison. And we can see that there's so much of potential space beneath the flavum. Sometimes it could be a bit vascular, especially when we are dealing with the periradicular artery that runs along with the nerve. But using these techniques, the bleeding can be minimized and we can work under clear visions. You can see the nerve roots are here, the disc material here, and the thicker sac, the spinal cord is over the medial to the disc. So this is the exposures of the nerve roots, the spinal cord, as well as the disc. So from this angle, we can perform discectomy very safely with adequate space to work. After discectomy, this is what happened to the nerve roots. So we can pretty much insert our nerve hook underneath the nerve. The nerve has become more mobile. You can see that it moves with the water flow, and at the same time, we can see that it become more reddish due to reperfusion. Again, same thing post-op. The patients has a quick and fast recovery after the surgical treatment. As a conclusion, I think that biportal spine surgery offers simple, minimal invasive solution for various spine disease. It offers the endoscopic minimal invasiveness, yet is as effective and powerful as open surgery to address complex spine conditions. I think that as the surgeons refine our skill and knowledge, I think that biportal spine surgery has the potential to revolutionize spine surgery and enhance patient care. Thank you very much, and these are my reference.
Thank you so much, Dr. Aaron, for your presentation and sharing about biportal spine surgery. So I can summarize about your presentation. So biportal spine surgery, or BSS, is a minimally invasive technique that uses two small incisions, allowing precise spinal procedure with minimal muscle dissection. It offers an advantage such as reduced tissue trauma, smaller incision, faster recovery, trauma, and lower complication rate. BSS provides a promising alternative to traditional open surgery with enhanced precision and reduced recovery time. Thank you, doctor. So maybe for the participants, is there any questions to Dr. Aaron about the biportal spine surgery? So maybe because there is no question, maybe I will ask the question to Dr. Aaron. So as you explained before and share about your cases, so is there any optimal candidate that we can do the biportal spine surgery safely? Is that all of the spinal procedure that we can do by the biportal spine surgery, or is there any criteria that we have to fulfill to do the surgery? Thank you, doctor.
Thank you so much for the questions. So I would confidently say that bipolar spine surgery has very wide indications. So previously, there was a belief that the bipolar spine surgery cannot be attempted over the anterior cervical diseases. But however, we have seen modifications of the techniques, and we have seen more and more people are doing bipolar spine surgery assisted anterior cervical discectomy nowadays. Other than that, the other thing is a tumor. It could be technically very challenging to perform resections of intradural tumor using the bipolar techniques, but we are seeing more and more experienced surgery doing that for tumors such as meningioma as well as a schwannoma.
Okay, thank you so much, doctor. So there are a wide variety of cases that we can done and perform the operation by the biportal spine surgery. Okay, thank you so much, Dr. Aaron, for your insightful presentation. So this presentation is the last presentation for the online presentation in International College of Surgeons. Thank you so much for your time and sharing, Dr. Aaron. So I will
Thank you very much.
Thank you so much, Doctor. I will proceed to the offline presentation. Thank you.
More than 50% case because of the male factor, okay? And maybe about 30% because of female factor. And then we can categorize into causes. The first is obstructive. Sometimes the urology using the sperm retrieval to get the sperm. And then non-obstructive, the problems is in the hormone level. Yeah, disbalance, okay? And then also the coital and sexual problems, okay? Because of the therapy of the cancer, maybe will affect the sexual function also. Next. Yeah. This is for the cancer and infertility. Like I said before, all cancer treatment options can negatively impact to the fertility. Testis is the one most of the sensitive organ in the body. So contains of many germ cell, yeah, many important germ cells, and also can disrupt, yeah, because of the treatment of the cancer, especially the spermatogenesis process and also the sex hormone production related to the Leydig cell decrease. Yeah, testosterone production will be decreased. Some analysis will be disrupted. Yeah, especially the concentration, the motility, and also the morphology. And also the DNA fragmentation of the sperm will be increased. So nowadays we use the DFI, yeah, we call DFI, to assess more sensitive for the fertility status of the male. Next. Yeah, this is also, I think, radiotherapy can still have irreversible effect on the testicular function and the fertility. So from the literature that I read, yeah, many radiotherapy in a small amount or in the small, what we call gray, the intensity can affect the testicular function and also making the infertility become decreased. Chemotherapy also have deleterious effect on the spermatogenesis, especially Leydig cell function. So the testosterone will be decreased and many problems in the patient. Hypogonadism will be happens and also the spermatogenesis will be decreased. Disruption of the genitourinary system is unavoidable in either cystectomy and prostatectomy surgery procedure. Maybe this is related to the urologist competency. Okay, next. Yeah, this is a table can explain that the common chemotherapeutic in male infertility. Maybe we can see platinum-based agent. This is, I think, from my literature. This is the most common agent for the chemotherapy, and also can making the spermatogenesis effect. Yeah, possible the chromosomal aberration and also the DNA fragmentation will be increase. I'm sorry. Next. Yeah. I also put this research, yeah. This is survey from Garrido Colino in Spain. Yeah. He making a big survey, yeah. Involved by, I think, 200 hospital and also maybe about 1,000 patient participant who involved this screening. Okay, so we can see here, yeah, the patient say there is no information from the hospital about the fertility registration after they get the cancer therapy. Next. Next, yeah. This is also, yeah, the patient tell, yeah, about 50% of the service in the hospital in the Spain not telling about the, or not receive the fertility preservation. Maybe in Prof. Ngura, I think the fertility centers now very good, yeah, have a what we call technology, yeah, the good technology. I see they have MIRI, the latest one MIRI, yeah, we can see all the what we call all the step of the embryo growth and development. Next. This is the fertility preservation, yeah. I read from the ASCO, American Society of Clinical Oncologists. They also echo about this issue, about the fertility preservation. So they also tell the patient must be referred to the fertility preservation specialist after they get the treatment, especially the patient who's still young or unmarried. This is also the last one, yeah, the sperm preservation and artificial reproductive technology include. And also they recommend to have in the same unit, in the same hospital with the oncologist therapy. Next. This is the algorithm. If we can find the patient with the risk of infertility or want to have a baby after before or after the therapy of cancer. Yeah, we can ask. There is also, we can find the interest, yeah, and then refer to the specialist, like this one. For the male, we can cryopreserve the sperm, yeah, we can freezing the sperm, yeah, and then the female, we can freezing the oocyte and also the embryo. And also, many research tell about the testicular fluid and also the ovarian tissue. We can cryopreserve, but still in the research. Okay, next. This is the indication to offering the fertility preservation from Santa Bala. Maybe you can read this one. Yeah, males, yeah, advanced and complete puberty. Yeah, we hope this one presents the spermatozoa in semen and testicle. This is the good condition for fertility preservation. And also there is some notes for the specification, like the patient under 2 years. Yeah, okay, so we cannot making the indication individualized. Okay, next. Yeah. This is the modality and how to collect the sample, the sperm. Yeah, semen sample is collected by masturbation. This is the best one, the most procedure to collect the sample. And then if the patient have a problem with the ejaculate going to the what we call to the vesica urinary, we can sampling the urine after ejaculate, and we use the alkalization agent. Okay. And the third, we can use the hormone therapy if the patient have a hypogonadism or low testosterone, but the research and the literature say it's not work well. And this is the LESWT, yeah, light extra shock wave therapy. Yeah, this is good one. And also we can use for making the erection, making the vascularization in the penis become more good, vibratory stimulation, and also electro-ejaculation. And the last, this is the fourth from the Schrader et al. In 2003. Yeah, they tell about the oncotase. This is the technique to collect the sample from the testicle who have the tumor or maybe have a cancer. Okay, you can see the picture. They find the bulb or the enlarged tube. They can extract from the tubes, and then as an andrologist, I will check if there is a sperm or not. If there is a sperm, I will collect all the sperm and freeze. Okay. This is we need what we call with the urologist or with the surgeon to work to work this one to get the sperm more collected. Okay. Next. This is the last maybe before finish my presentation. Okay, so the sperm cryofraction or sperm bank is achievable pregnancy by the insemination urinary, but the percentage or the success rate is low, still low. In vitro fertilization, conventional, we put the sperm in the egg, yeah, the enough sperm, and then the last one we use the ICSI, intracytoplasmic sperm injection, and the success rate up to 40%. This is like the normal condition. Okay. Next. Yeah. So based on my presentation, so this is the simple presentation for me to introduce the importance of fertility preservation, not in male, the female also. Okay. So male infertility is known as a side effect of cancer therapies and dependent largely on the therapeutic regimen. Okay. And then educate about the reproductive capacity, provide the resource regarding the preserve fertility. We hope the oncology center with also the fertility center is near, okay, can also communicate about the patient, and interested patient should be directed to the Center of Fertility Preservation Specialist. So that's all this is my reference, and also that's all my presentation today. So this is in Bali, it's a holy day, the 5th full month. So like the Balinese, they always pray because this is the good day to have what we call welfare. Okay, but as an andrologist, as a fertility specialist, we always pray the moon is not coming. Okay, so the patient is pregnant. Okay, okay. Thank you. That's all my presentation. Nice to see you. Good afternoon.
Thank you, doctor. I will invite to all speakers to come forward for discussion. to all audience. Any question? Yes.
Good afternoon, Professor and doctors. Thank you for the opportunity. My name is Ayu. I'm a medical student currently undergoing my surgical rotation. Allow me to ask two questions. So the first question is, allow me to ask to Dr. Putu Pramana Sarjaya, as the anesthesiologist. I mean to ask, does the use of nitrous oxide as the substance that we usually use to enhance the second gas effect and also as the analgesic agent, does this have a certain association or certain influence on the recovery rate? And should the use of nitrous oxide gas be encouraged in surgeries, especially surgeries that will result in high pain skills, such as laparoscopic surgery with the CO2 insufflation? Thank you.
I can answer direct. Yes. Yeah. Thank you for the nice question. We are now tend to discourage use of nitrous oxide. We use a very short acting regimen. Even in in our hospital, I think in most hospital now they don't use nitrous oxide anymore. We tend use only short acting agent, total intravenous, and the gas we use also the short acting one, like desflurane and sevoflurane. I think in the whole country they tend to use a very short acting drug in anesthesia. Why? Because it's way easier to titrate. Give more, give more, give more. Then once we give drug that work quite long, and then let the body metabolize. So way more complicated, especially if they perform the laparoscopic or they use other gas. We don't use. We try to simplify everything now in anesthesia. I think it's answer your question.
Thank you, Dr. Pramana, for the answer. It explains a lot. And for my question, for my second question is for Dr. Pram, the andrologist. Excuse me, doctor, allow me to ask a question. So as Dr. Pram has explained earlier, that we know there are latest advancements in the fertility preservation techniques, such as the ovarian tissue cryopreservation and also in vitro gametogenesis. What I mean to ask is that how do these techniques compare to the conventional methods in terms of success rates and also accessibility for the public? Thank you.
Thank you very much. I know you very well. Yeah, because also my student. Yeah. Nice question also. Yeah. So yeah, like I said before, yeah, the advanced technology in reproductive is the latest one is ICSI, yeah, intracytoplasmic sperm injection, and have what we call the success rate is very high. Yeah, up to 40%. But like I said before also, yeah, there is a conventional technique of the IVF, in vitro fertilization. We put the sperm, yeah, in some concentration, and then let the sperm find the eggs in media. Okay, but the success rate is not a good one. Maybe less than 40. Okay, and then the ones left is the insemination intrauterine. So insemination intrauterine is also the basic one of the artificial reproductive technology. We prepare the sperm, yeah, and then we transfer the sperm to the ovarium, and yeah, let me see, yeah, the fertilization will be happen, and about the success rates only about 50%. Okay, in commonly the success rate is only 50%. And how about how to access the fertility center here? I think in Bali there is until now we have 6 fertility center. So I think in Bali, yeah, we can access well the center, but the center is not spread what we call well, yeah, only in the big city like in Java or in Bali. So we need to making the center in all the in Indonesian. Oh yeah, okay. So we have we need the spread the center more spread well. Okay, so maybe that's my answer for you. Okay, thank you.
Have any question? Any others? Yes.
Okay. So good afternoon to professor and doctors. Thank you for the opportunity. So my name is Shannon Kalista and I'm a medical student. So my question is for Dr. Win. So the question is, with the stem cell therapies, which are still being costly and experimental, so what are the steps that can be taken to improve or increase the accessibility and also the affordability for people or for patients in developed or developing healthcare systems? Thank you.
Thank you. This is a very good question. And then if we talk about the stem cell treatment in Indonesia, this is the burden is regulation. And the government already make a regulation. This is not all the hospital can make the stem cell treatment. One of the good things and one of the hospital they can make the treatment the cell therapy is in Sangla Hospital. That's why we will start maybe launching next month. We have a small meeting, and then but still they support by some company. Then they will start to some. We already start some research, especially we already make our many of our staff, especially orthopedic and biomedic PhD, they already have the stem cell research. But nowadays, that's why that I mentioned in my last conclusion, we should further research in the human. There's the ethical clearance is the problem. It's still you must start in slow, but the things that we already start. We already have the new hope that for the degenerative disease later we can make a good result. At least we can cure. This is our hope. We can cure the degenerative disease, especially on the osteoarthritis, because now we still keep in symptomatic treatment. We just talk about the joint mobility. We just talk about the quality of life. Later we talk about how to cure with the generative medicine, especially with the stem cell treatment. But still, the burden is the regulation. But we still, but now we make hope with the Sangla Hospital or Pura Hospital has become one of the stem cell service in Bali. Thank you.
That's enough for me. Thank you so much for the explanation, Doctor.
Please, Dr. Peters.
Thank you, moderator. I have 2 questions. The first question is to Professor Sri Maliawan. You said that most of your cases is preschool children with the hydrocephalus and with the treatment of VP shunting. My question is how you take the informed consent from the parents, because his mother is unautonomous individual, so you have to take the informed consent from the parents. Is there any burdens or challenges
about asking the informed consent from parents. And is it, should we one by one, or I can proceed with the second question? One by one, okay. Okay, thank you. This is a very good question. So, hydrocephalus, congenital or acquired for young children, for example, is very between mild, severe, and moderate, something like that. In very severe cases, some literature said if the mantle cortex less than 1 centimeter, you can consider to terminate the the pregnancy at that time. You can by statistic evaluation that in 1 centimeter mantle less than 1 centimeter you cannot achieve. I think it's very difficult to the patient grow and so on. But some report 2 days after birth, less than 1 centimeter, they are doing PP scan, and then after 10 days, 10 years, he survived, and then the brain was grow, the grow and the circumference, head circumference is control look very normal. Okay, so when I asked him, and he said, "Where is it? Where did the brain come from?" He said, "I don't know. It maybe come from the sky." He said, "Okay." So, but whatever, it grow when they handicap like that. Okay, a little movement, a little alteration. I mean, a little progress. For example, on pelagic hand, when you can move one leg like that, oh, you're very good like that. Okay, it never come to normal and severe. Okay, so for informed consent like this, in very severe, and in my experience like this, we should tell the patient and the family, not the patient, the family, that the prognosis should be sent like that and so on. And don't forget to mention that don't worry, you both, it's already take care of your children to come here and have the best examination and treatment. If it doesn't success, for example, he will die and so on, complication, something like that. You don't have to very sad because you already get the best treatment for this. Okay, don't forget say like that. Yeah, but some of the patient, most of the patient, I operate PP son now become a doctor. It doesn't matter. Okay, it's good. Some can become a doctor, some engineer, and so on. So as long as you are gradually or you are regularly, if there's any problem, just direct come to the center who have neurosurgical services like that. Yeah. So informed consent is what we say is mandatory. You should explain to the family everything regarding the causes of this. So if you want to make a new baby, for example, they make sure you will doing detailed examination related his diseases, related his congenital anomaly of his children. And even it just mild hydrocephalus, you should deliver informed consent in detail. What is the progression? What is the achievement? What is the outcome of the treatment? What is the complication and so on? Yeah. So you must know that the patient, the family who has hydrocephalus children, yeah, they suffer so much. So explain patiently to the patient, to the family, yeah, and explain from the A to Z, yeah, to Z, what will happen to his children. Just that. Thank you. Thank you, Professor Maria. May I proceed to my next question? Yeah. So, Dr. Pramana, anesthesiologist.
usually the anesthesiologist work together with the surgeon. So if the surgeon would like to perform a surgery, they ask for informed consent for the surgery. So how about the anesthesiologist? Did you ask for informed consent separately, or just you follow the informed consent from the surgery? That's the first question. The second question is, ask for informed consent in the surgery with local anesthesia.
Thank you, Professor, for the question. We anesthesiologists ask for we do the information and take the consent separately, and we take consent from any procedure, not only general anesthesia but also to regional anesthesia, even monitor care. For example, we do very severe case patient. They're just doing for example, MRI, severe, and anything can happen anytime, and we take the consent. Yeah.
But even for the minor surgeries, yeah, like excision of the soft tissue or circumcision, that use only local anesthesia, lidocaine injection. Did you take anesthesia informed consent from this patient?
Yes, of course, of course.
That's good. Thank you.
Thank you.
Okay, thank you. Because the time is up, it's mean finish the second session. Yes. Thank you for all speakers for discussion, and good time.
Thank you for the informative and outstanding presentation from our speakers. We would like to invite all our speakers and moderator as well to come forward and to receive the award of appreciation that will be given by Dr. Francis Podilski and the FICS as the Executive Director of ICS. And to all the attendees of the seminar, please feel free to enjoy the lunch that has been provided. So in the count of 3, 1, 2, 3. Please give a warm applause to our moderator and speakers.
Ladies and gentlemen, while you enjoy your lunch, we will continue the event with the announcement of the e-poster competition winners. For all poster participants, please embrace yourself because you might be one of the winners. We will start with the third place. The third winner with total score of 428 goes to Dr. Andre Gunawan with case report pseudopapillary neoplasm in child. For the second winner with the total score of 443 goes to Dr. Pande Ayu Kirana Dewi with loop ileostomy versus colostomy after anterior resection for rectal cancer. And for the first winner with total score of 449 goes to Dr. Christopher Lauren, Joshua Sutikno, and Dr. Anki with ventricular peritoneal shunt associated giant intraperitoneal cerebrospinal fluid pseudocyst. For all the winners or the representative, please come forward to the front to receive the prize. And we would like to invite Dr. Francis to give the certificate. Congratulations to all winners of the e-poster competition.
So we have finally now come to an end of our event. We would like to express our heartfelt gratitude to all the speakers, moderators, and participants who have dedicated their time and attention throughout this event. On behalf of the organizing committee, we apologize for any inconvenience throughout this event. We close this event with Paramasanti, Om Santi 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 Om. Good afternoon and see you on the next events. Thank you.
Okay, we talk about more.